está previsto para entre 10 e 20 e 10 e 30. Retornamos 10h30 e vamos até
Retornaremos às
11h50
30 e
com a
vamos
condução da
hasta
mesa número
11:50
5,
com a mesa número
mesa redonda
5,
número 5, até
hasta
11h50,
las
quando teremos um
11:50,
período de
cuando
debate de
tenemos
20
un
minutos
periodo
entre
de
11h50
debate
e
hasta las
12h10.
12:10.
Saímos para o almoço,
Salimos
retornamos
del
do
almuerzo,
almoço às
volveremos a las
13h15, 1 hora,
13:15,
portanto, previsto
una
para o
hora, por
almoço,
lo tanto, para
e
el
iniciaremos com a mesa
almuerzo,
redonda número
y
6,
iremos a la mesa
prevista
número 6,
para esse período
prevista
entre
para ese periodo
1h15 e
entre
2h15, 13h15 e
13:15 hasta las
14h15, quando teremos
14:15.
um novo debate em torno
Tenemos
dessa
otro
mesa, né?
debate
De 14h15
para esta
a
mesa hasta
14h35,
las
período de debate,
14:35,
e aí
periodo de
então
debate.
nós iniciaremos uma mesa final aqui
Iniciaremos
com as
una última
considerações
mesa con las
finais. É uma
consideraciones
mesa
finales.
prevista para
Una
durar até
mesa
às 15
prevista
horas,
para
quando
durar hasta
encerraremos o
las
nosso evento.
15 horas, cuando
Ok?
vamos
Então,
a cerrar
colocado
nuestro evento.
a programação ajustada,
Entonces,
nós
ajustando todo
iniciaremos
eso,
então, conforme
iniciaremos
anunciado, com
entonces
os
conforme
lançamentos. Lançamento da
eso, el
publicação
lanzamiento de la
Iniciativa
publicación,
Rede Colaborativa
iniciativa Red
Brasil,
Colaborativa
estudo de
Brasil, estudio de
caracterização clínica
caracterización
e
clínica,
manejo de
el
pacientes
manejo
hospitalizados
de
com
pacientes
Covid-19, contribuindo
internalizados
com o
con
SUS
COVID-19, contribuyendo
e
con
a
el SUS,
plataforma
la
clínica
plataforma
global da
clínica global
OMS.
de
E
OMS.
também o lançamento
Y
da
también el
página
lanzamiento de
web
la
da
página
plataforma
web
da Rede
de la
Colaborativa
plataforma de la
Brasil.
Red Colaborativa de
Para os
Brasil.
lançamentos,
Para los
gostaríamos de
lanzamientos,
convidar para
me
que
gustaría de
tome lugar à mesa
invitarnos para
diretora,
que
por
venga a
favor,
la
senhor
mesa
Roberto Tapia
señor
Hidalgo,
Roberto
coordenador de
Tapia,
Sistemas e
coordinador de sistemas
Serviços
de
de
servicios de
Saúde,
salud,
OPAS OMS Brasil.
OPAS
Seja
OMS
bem-vindo.
Brasil.
O coordenador,
Bienvenido,
por favor,
señor
fique à vontade para
coordinador.
tomar o seu lugar no palco. Convidamos também
Le
para que venha
invitamos
ao
también para
palco,
que venga a la mesa.
sim, Ludovic
En el escenario,
Reveis, por
Ludovic
favor,
Reveis,
assessor
por favor,
regional do
asesor
Programa de
regional del
Evidência
programa
e
de evidencia
Inteligência
de
em
inteligencia
Saúde.
en salud.
Por gentileza, queira tomar também
Por
o
favor,
seu lugar no palco.
venga a
E convidamos também para que
su silla,
venha tomar aqui o seu lugar à
que venga
mesa
también
Rosane
para la
de
mesa
Mendonça Gomes,
Rosane de
consultora
Mendonça,
técnica
consultora
de
técnica de
sistemas e
sistemas
serviços
y
de
servicios
saúde,
de salud,
OPAS OMS
OPAS
Brasil.
OMS
Por favor,
Brasil.
queira também,
Por
Rosane, tomar o
favor,
seu lugar à mesa.
puede
Por
venir
gentileza.
a la mesa su silla.
Senhores, sejam bem-vindos. Para
Señores,
palavras iniciais, com a palavra, o
bienvenidos.
coordenador
Con
de
la
Sistemas
palabra
e Serviços
el
de Saúde,
coordinador
Roberto Tapia Hidalgo, o senhor tem a
Alberto
palavra.
Talpa tiene la palabra.
Buen día a todo el mundo.
Buenos días a todos.
Bueno, quiero decir que iniciamos un nuevo día, ya el día de encerramiento de esta actividad de la Red Colaborativa Brasil para pesquisa de COVID-19. Y bueno, un buen día, terminamos bien ayer, bastante relajados, todo el mundo pudo disfrutar del partido. Nosotros aquí en la pantalla más grande que yo he tenido para ver un match de fútbol. Bueno, vamos a empezar un día con una actividad interesante para nosotros, con un producto bien especial, que significa concretar un esfuerzo de ya casi 2 años. Y ahí quiero solo dar unas palabras para compartir con la audiencia aquí el tremendo esfuerzo que ha significado esta publicación, y que se resumen, yo diría, 3 cosas. Primero, las 2 etapas del proyecto de red colaborativa: la etapa de pesquisa de COVID agudo, y la segunda etapa, que ha sido el esfuerzo para ir hacia una forma, una metodología de pesquisar COVID longo. ¿Ya? Y eso está reflejado en los 2 componentes fundamentales de esta publicación. Aquí hay un esfuerzo muy grande de los hospitales, de cada uno de los equipos de pesquisa que cuentan esos hospitales, también del Ministerio de Salud, y también acá de la coordinación de OPAS, con todos sus técnicos en todos los ámbitos, desde la coordinación del proyecto hasta la metodología misma y hasta los elementos de producción y diagramación de esta publicación. Y solo quisiera dar cuenta también que para mí, que valoro mucho estos productos bien concretos, significa ya tener una imagen, un logo, una identificación de este esfuerzo que va tomando forma, una iniciativa nueva que no existía hasta hace 2 años atrás, y que es un producto, una herramienta que estamos construyendo entre todos para Brasil. Así que solamente diría eso por mi parte. Como coordinación, es sumamente grato poder entregar un producto concreto después de tiempo largo de trabajo. Así que paso aquí la palabra a Roxana.
I'll give the word for who next person who wants to speak.
Bom dia a todos.
Buenos días a todos, todas. Buenos días, doctor Ludovic, doctor Tapia.
Esse é um momento
Ese es un momento de gran alegría que nosotros
essa publicação,
lanzamos esta publicación, ese esfuerzo colectivo de todos los pesquisadores, investigadores e instituciones que están con nosotros desde 2020.
E que nesse momento,
Que en este momento nosotros logramos traer efectivamente un producto, además de la publicación que tuvimos en la pasada, en la OMS, en el artículo publicado. Y ahora traemos el esfuerzo de esa nueva etapa que tuvimos ahora en 2022. De todo un proceso de construcción de esta investigación, de esa elaboración, es una publicación técnica, y nosotros sabemos que es un punto inicial de un proceso de evidencias, de publicación, de artículos que irán a seguir. Y tenemos cuestión de trabajar, de un esfuerzo enorme, muy grande, para que dentro de un tiempo cierto logremos de tener esta publicación hoy. Entonces es con gran alegría que nosotros traemos a esta publicación. Y me gustaría pedir permiso para rápidamente
uma breve apresentação
una pequeña presentación de Vanessa con la construcción conjunta de nuestra periodista y colaboradora de Sistema de Servicios de Salud. Entonces, muy rápido.
Volta, Vanessa, por favor. Só. Então,
Entonces,
essa publicación
trae como resultado de esta investigación de la contribución de todas nuestras instituciones participantes, de los investigadores, con la alimentación de la plataforma, que sin duda Ronaldo
buscando un
retorno a Ginebra,
que essa
y que esa contribución que nosotros pasamos de aproximadamente 20.000 casos registrados en el último año, pasamos a obtener 78.581 casos registrados en la plataforma de OMS. Entonces, nosotros tenemos acá un envío directo, tuvimos dos formas
de alimentação da plataforma,
una que fue un grupo de hospitales que inicialmente no estaban haciendo parte del Data Hub, acompañar por toda la presentación. Nosotros tuvimos también un envío directo del Data Hub de los hospitales que se conformaron a esta red inicial para el Data Hub, el total Brasil de 78.571 casos. Más adelante tenemos la proporción por la región de salud.
Então, nós temos aí por região.
Entonces tenemos por región de salud. Por regional tenemos la Nordeste con 33.730 casos.
A região centro-oeste,
la región centro-oeste, sudeste, con un total de 22.589 casos. Tenemos la región sur con 14.959 casos y en el norte 1.847 casos. Entonces, así, pues es importante traer acá en el caso de región norte, porque nosotros en esta nueva etapa, tuvimos la felicidad de traer otras instituciones, como fue de la Secretaría de Espírito Santo, los hospitales de USP, Ribeirão Preto, de São Paulo. Tuvimos
o Hospital Regional do Baixo
Hospital
Amazonas,
Regional
nós não
de Bajo
tínhamos
Amazonas.
contemplado na
Lo
etapa
teníamos
anterior
contemplado en
região
la
norte.
etapa
Então,
anterior, la
assim,
región
nós
norte.
tivemos aí
Nós
o IME, o
tuvimos
hospital. Então,
el
são
MIP,
hospitais
hospital.
novos
Entonces
que
son
chegaram
nuevos
e
hospitales que
realmente, assim,
llegaron,
só
que
cresceu
realmente solo
e fortaleceu essa rede
fortalecido esta
colaborativa.
red
O
de
hospital de
colaboración.
Eduardo,
El
da
hospital
pessoa
de
idosa,
Eduardo
da
de la
pessoa idosa
persona
em
mayor
Pernambuco.
de
Então,
Pernambuco.
assim, a gente
Entonces,
só
así,
tem a agradecer
solo tenemos a
todo esse
agradecer
esforço
todo esse
coletivo. E
esfuerzo
aqui a
colectivo.
gente
Y
fecha, né, com
acá cerramos
a
con la
publicação da
publicación
Rede
de la
Colaborativa
Red
Brasil de Pesquisa
Colaborativa Brasil
Clínica,
de
que reuniu
Búsqueda de Pesquisa Clínica,
aproximadamente
que
90
he reunido
pesquisadores
¿cuántos?
envolvidos na
90
produção, né, dos relatos das
pesquisadores e
experiências
investigadores
dos
con sus
hospitais
experiencias y los
participantes
hospitales
na
participantes
publicação.
presentes en la publicación.
Essa publicação ela
Esta publicación
reflete este esforço
refleja
coletivo da
este
rede de
esfuerzo colectivo de
pesquisadores e o
la
compromisso da
red
OPAS com a
de
produção de
pesquisadores e
conhecimento.
investigadores de la red OPAS de
Permite, e está aí
conocimiento,
toda uma
permite
análise em relação,
hay
né,
toda una
descritiva em
análisis
relação ao projeto de sua
descriptiva con relación
governança
al
no Data
proyecto
Hub
de
e a
gobernanza en la
iniciativa da
base de
OMS,
datos
corroborada
relativa a
pela
OMS,
Rede Colaborativa
corroborada para
Brasil
la
de
red
Pesquisa
colaborativa
Clínica, ela
de
se coloca
pesquisa
como
y búsqueda
recurso
clínica que se
potente para
coloca
os
como recurso
pesquisadores
potente
brasileiros,
para
além
los
de apoiar os
investigadores
gestores
brasileños,
de
además de
saúde,
apoyar a
âmbito
los
federal,
gestores
estadual
de
e
países,
municipal,
además de
na
apoyarlos
implementação de
en el municipal y
políticas
estatal, la
públicas
implementación
de
de
saúde para
políticas
o
públicas de salud
aprimoramento do
para el
SUS.
aprimoramento del
E
SUS.
aí, por favor, Vanessa.
Por favor, Vanessa.
Então, aqui a gente traz,
Entonces acá traemos
com esse esforço,
con ese
tanto da
esfuerzo, tanto la
publicação, né, e aí
publicación,
com o apoio
con el
da
apoyo
Vanessa, né, e equipe,
de Vanessa y todo el equipo,
estrutura
esa
que é
estructura
inicial e que com certeza
es
vocês
inicial y
vão
que
poder
sin
estar
duda
contribuindo,
estarán pudiendo
né, na
contribuir en
implementação,
la
em
implementación,
que tem uma
en
página da
que ya
plataforma
tienen una página de la
Colaborativa
plataforma
Brasil,
colaborativa de Brasil,
que a gente
que
vai estar
nosotros
fazendo a alimentação,
estaremos
né,
haciendo
de
la
todo esse processo de
alimentación de todo
pesquisa,
este proceso de
perspectiva
búsqueda,
de o dashboard
investigación, de pesquisa de
para que a gente
dashboard,
possa
para
alimentar
que
e aí com
podamos
certeza
alimentar y sin
com o
duda
apoio
con el
da
apoyo
equipe da
del
OMS, aí
equipo
com o
de
Ronaldo, a
OMS,
Vanessa está o
Ronaldo,
tempo todo já
Vanessa,
interagindo
están
com ele,
todo
para a
el
gente
tiempo
poder
interagindo,
estar fazendo
estar
essa
haciendo
divulgação
esta
e essa
divulgación y
alimentação.
alimentación
O site
de
ele
datos.
está dentro
El
do portal da
website
inovação,
está en
né, da
el
PS
portal de la
Redes,
innovación
então
de la
assim a gente
PS Redes.
amplia
Entonces
o site
ampliamos,
com mais
aumentamos
essa
el website con
essa
más esta
dimensão em
página web,
relação a esse
con esta dimensión,
projeto.
con relación a este
Pode
proyecto.
passar, Vanessa? Bom, então acho que nesse
Entonces
momento,
creo que
doutor Tapia,
Dr.
como
Tapia
é uma forma simbólica,
es
mas
una
assim,
forma
primeiro,
simbólica,
né,
pero
colocar aí
primero,
o senhor podendo,
el señor
em agradecimento
poniendo
aqui
en
à Organização
agradecimiento en la
Pan-Americana da
Organización Panamericana
Saúde,
de la Salud,
e com o seu escritório,
con
né, da
su
sede em
oficina,
Washington,
con
pessoal
sede
do
en
Dr.
Washington,
Ludovic,
la persona del
podendo
doctor
passar aí
Ludovic, pudiendo pasar ahí
o livro, né,
el
para
libro
ele.
para él.
E nós queríamos aqui
Nosotros
chamar, em nome
gustaríamos
de
de
todos os
llamar
hospitais, já que
en
não
nombre
dá
de
para
de
todos
los
irem, vai
hospitales,
estar sendo,
como se no
já
puede
está sendo
todos vinieron, ya
distribuído,
está siendo
né, o livro
distribuido
para todos.
el libro para
Nós
todos.
queremos chamar aqui
Me
o Dr. José
gustaría
Piatto,
llamar
né,
el
como
José Piatto
diretor
como director
da rede
de
EBSE,
la red EBSE,
de atenção à
de
saúde,
atención a la salud,
da EBSE,
de la EBSE.
e sintam-se em nome dele,
Sí,
né,
sí,
o
pueden
agradecimento
sentirse el
a
agradecimiento a
as
todas las
instituições que fizeram
instituciones que hicieron parte de este proceso.
Por favor. Eu acho que a gente,
It's okay.
nesse momento, a gente pode quer colocar alguma.
Good morning, everyone.
Buenos
Good
días a
morning, Dr.
todos,
Tapia,
Dr.
Dr.
Ludovici.
Ludovici,
Muito
Dr.
obrigado.
Buenos
Rosani.
días a todos. En
Thank
nombre
you
de
very
todos
much on
los
behalf of
hospitales, no
all
solo
the
de la red
hospitals,
EPSAT,
not just
pero
on
todos que
behalf of
contribuyeron
EBSEB,
con
but
eso
everyone
de
that has
una manera muy
contributed to
intensa,
that in a very
de un momento
intense
difícil,
and difficult
donde hay
time
nuevas
where
tareas,
new tasks had to be
tareas
done
nuevas,
and to
traer
bring this kind
esos
of
datos de
data
esa tamaño para la
within the
plataforma de
platform
la
of
OMS
who
trae un destaque muy
brings
importante para
a
el país.
highlight to the country.
No solo para
Not
quien ha
just for
trabajado
those who
en este
have
momento,
worked at
pero
the
como
moment,
país,
but
institución,
for
hay
the
que
institutions in our country
todos los países de América
and all the
contribuyeron
countries in Latin America have
para esta
contributed to
iniciativa
this
global
global
de la
initiative of
OMS,
WHO,
trayendo datos de una
bringing
población que
data
muchas veces
from
es
a
olvidada.
sometimes forgotten population.
Só mais uma vez
So once
Entonces,
again,
una vez
I would
más
like to
agradecer
thank
a
everyone
todos
toda essa
por
trajetória
for
toda esta
this
trayectoria
whole journey.
muy
aqui
rica.
agradecimento
Acá un
Now I
agradecimiento
would like to
especial
thank
al Ministerio de
especially
Salud,
the Ministry of Health
la atención
and
hospitalaria
the
domiciliar y de
Department
urgencia,
of
que fue
Urgency
nuestro
Care, which
parte
was our partner
el
since the
inicio de
beginning
este
in
proceso de
this
construcción
process of
conjunta.
joint construction.
No sé, sin ninguna
So we
hipótesis,
cannot forget
podemos nos olvidar de este
about
coparte del
our
Ministerio de
partner
Salud.
Ministry of Health.
Cada vez
And once
más
again, I would like
agradezco
to
todas las
thank all the
instituciones
institutions that have
participantes
participated.
y claro,
And of
la
course,
Organización Mundial de
the
Salud por
WHO,
esta
the World Health
belísima iniciativa,
Organization, giving us
de
the
dar la oportunidad de
opportunity
nosotros
to
de
develop
desarrollar
this
este proyecto
project. It's a
magnífico.
wonderful project.
No
So
sé,
thank you
muchas
again.
gracias y creo que
And
cerramos
now I
acá.
think we can close the
Ah,
ceremony.
perdón.
Oh, I'm sorry, I
Muy
forgot.
rápidamente porque sé que estamos contra el tiempo también.
I'm sorry,
Bueno, primero que
I'm going to
todo,
go fast because we don't have a
felicitaciones
lot of
por la
time.
publicación.
So
Yo
first
creo
of
que
all,
es
I am very happy
un logro muy
because of this
importante tenerla.
publication. I think
Algo
this
que a mí
is a
particularmente siempre
very
me ha
good
llamado la atención
accomplishment
y que
and
tratamos
something that
precisamente
always calls
este
my
año
attention
de
because
estudiar de una manera
we
mucho
have
más
dealt
sistemática
this
es
year
por qué,
with a more
por qué
systematic
los grupos
way
colaboran, ¿sí? Y
to
por qué existe la
study
colaboración.
because
¿Sí?
the groups
Que,
collaborate because
y
there is
esto es algo que
collaboration.
pues ocurre desde hace muchísimo
Well,
tiempo,
this is
redes y colaboración e
something that
investigación.
can happen
Y
for a
en
long
muchos de los
time in
proyectos que yo he
research,
estado en
and
los
many of the
últimos 2
projects that
décadas,
I
algo que es
participated in the last
particularmente
2
interesante
decades,
para mí, o sea, nosotros
and
hicimos
that
toda una
are
revisión
very relevant
sistemática,
for me,
tratamos de ver de forma
they
mucho más rigurosa por qué había
underwent
colaboración,
a
cuáles eran las barreras,
review
cuáles eran los
in a more
facilitadores,
rigorous way
cuáles eran los
because we want
incentivos,
to know
etcétera.
what are the
Pero
challenges
hay un
and
punto
incentives for
que para
these
mí yo creo que es
collaborations.
primordial y es
But I think
eh,
one thing that is really
cuando
important
hay
for
un
me
objetivo difícil
is when
y
we
que
have a
parece muy complicado,
challenge
creo que eso
that seems very
despierta entre
complex and
todos la
difficult.
necesidad de un
I
trabajo
think
colaborativo. Hay un reto
this
adelante y
makes
eso une a las
everyone to
personas.
work
Yo
in a
creo que en
very
este proyecto en
collaborative way.
particular tuvimos ese
And I
reto, o
think
sea,
that
tuvimos
this particular
un-
project,
una
in this
pandemia
particular
que
project, we had
teníamos
many
una gran
challenges
cantidad de
because of
incertidumbres,
the
problemas,
pandemic.
y eso nos unió a
And we
todos,
had a lot of
no
uncertainties,
solo al
a lot
personal
of
de salud, sino a
doubts,
los
a lot of
investigadores, a
shadows,
todos los
not just
gestores,
for the
en un
people in
objetivo común
health,
que era
but
tratar de
the
entender esta enfermedad
researchers.
y
They
seguir
have a
adelante.
common goal. They want to
Entonces,
understand this
en
disease
ese
and they
mismo
want to move
espíritu, yo creo
on.
que es muy importante consolidar
And I
esta
think
red de
that it is very
colaboración.
important to
O sea,
consolidate
pasado este
this
momento de trabajo y que ya se
collaborative
tienen unos logros,
network.
ir más adelante
And
para
there
estar
are
mejor
some
preparados
accomplishments, and we
y
have
lograr
to move
institucionalizar esto.
forward.
Entonces, por mi parte, mis
And we
felicitaciones a
have to
cada una de
conquer
las
even
personas que
more.
por Zoom o
So I
por
would like
Teams
to
conocimos
congratulate all
desde el
people
inicio,
that have
que vimos pues el
participated,
entusiasmo,
people
que
that we
trabajamos
have
conjuntamente
get to know
y
in
obviamente pues a los
person
colegas
or
de la OMS,
virtually,
a mis
all the
colegas de
colleagues
OPS que
from
empujaron en cada
WHO,
uno de los países, que
all
esto
the colleagues
realmente
from
fueron
PAHO, in each
proyecto que saliera
country
adelante. Entonces,
that
mis
we
felicitaciones a
have
todos. Muchas gracias.
participated. So I would like to congratulate everybody.
Bueno, muchas gracias a la mesa
Well,
que
thank
Giuseppe,
you.
Susan,
Thank you
Ludovic,
to the
vamos
table,
a seguir en nuestra agenda
Ludovic.
y vamos a
Now
ir a
let's
la
continue with
primera
our
mesa.
agenda.
Gracias.
And this table is closed.
Muito bem, nossos agradecimentos.
Muy bien, nuestros
everyone.
agradecimientos a los
Thanks to
señores que
everyone
integraron esta
Abre os
mesa,
trabalhos
que
participated in
abre
this
los
table
trabajos
deste dia
de este
e
día
promove o lançamento
promueve el
and that
lanzamiento
promotes
de
publicação
una
também,
publicación,
launching of
también
the
de publicación,
publication
el
da página
lanzamiento,
web
perdón,
and
de
also the
la
web
página web de la
page
plataforma de la red
Colaborativo Brasil.
about
Iniciamos
Colaborativo
então
Brasil.
as atividades
Collaborative
de
Entonces,
hoje.
iniciamos
Network
las
Nós
actividades de hoy.
passaremos agora a
Now
conduzir a
we're
mesa,
Pasamos
going
a la
redonda
to
número
mesa
4,
start with
com o tema
roundtable
compartilhando
4,
os
tema
resultados da
compartiendo
sharing
pesquisa de
resultados
experiences
de
caracterização
of
pesquisa
clínica
de
e manejo
post-COVID
dos
investigación
pacientes
clínica de
specialized
com
manejo de
self-care
Covid-19
los pacientes
e
con
segmento
COVID-19 y
and
pós-Covid
segmento
na
post-COVID
atenção
contribution
especializada.
to the
especializada,
global
Contribuição à
clinical
plataforma
contribución a
clínica
la
platform.
global
plataforma clínica
OMS.
global OMS.
Eu gostaria de
I would
convidar
like
Me
o
to
senhor
gustaría de
Paulo que
call
invitar,
venha
señores y
tomar o seu
señores,
lugar à
so
para
mesa
que
they
venga a
have a
la
seat at
mesa
the
para coordenar
table
as
para
atividades
to
coordinar
desta
coordinate
mesa
at the
redonda.
table,
O senhor
to coordinate
Fernando
the
Anchal,
table.
señor Fernando
Mr.
Anchal,
Fernando
por favor.
Anchal
Anchal é
is
coordenador
the
do setor de
Fernando es
coordinator of
pesquisa,
the
coordinador del sector de
research
gerência
pesquisa,
sector,
de
e
teaching
ensino
and
gerencia,
de
research
pesquisa
de
management
Grupo
pesquisa,
Hospitalar da
of
búsqueda
Conceição,
del Grupo
Porto
GEP, the
Alegre.
Hospitalar
Seja
Conceição
bem-vindo,
Porto
de
Alegre
Porto
Hospital
Alegre.
Group.
Fernando Anchal,
Welcome,
para essa atividade.
Bienvenido
Fernando
para esta actividad.
Anchal.
Nesse painel que pretende
Este
durar uma
panel
hora,
For
que
this
nós
pretende
panel
teremos
durar
a
that
una
apresentação
has
de
duration
hora,
of 1
instituições,
tenemos la
cada
hour,
uma
presentación
delas
de
com
tres
20
we
minutos de
instituciones,
have
cada una
exposição.
con
3
20 minutos de
E para
institutions.
representar aqui o
And
Hospital
to
da
para representar el
represent
Faculdade de
Hospital de Clínica
Medicina
de
de Ribeirão
the
Facultad
Preto, da
de
hospital,
Medicina
Universidade
the
de
de
São Paulo,
clinicas
Ribeirão
of the
Preto
gostaria de
de
Faculty
convidar
of
São
Antônio
Paulo.
Medicine of
Pazin
Ribeirão
Filho,
Me
Preto,
gustaría
University of
invitar
São
Pazin
Paulo.
Filho,
Antônio Pazin Filho,
professor
titular da
Antônio
Faculdade de
Pazin
Medicina de
Filho.
Ribeirão
Universidad
Preto,
de
da
Ribeirão
Universidade
Preto,
de
la
São Paulo,
Universidad
na
A
área de
de São
professor
Paulo,
emergências
en
in
la área de
the
clínicas,
emergencias
Hospital das
Covid-19,
clínicas desde
Clínicas of the
2019,
Faculty of
2019.
Medicine,
e também diretor do
and also
También
Departamento de
he's the
director
Atenção
del
à Saúde do
Departamento de
Director
Hospital das
of
Atención a Salud
Clínicas
del
da
Hospital
Healthcare
de
USP.
las
of
Seja
Clínicas de
bem-vindo,
USP.
então,
USP.
professor
Entonces,
Antônio Pazin
bienvenido,
Filho.
señor
Welcome, Mr.
Antonio.
Pazin
Convidar também
Filho.
para que venha
A
ao
Dr.
invitar
palco,
también
Pazin
para que
Filho.
representando
venga
a
al
mesma
escenario,
Also
instituição,
to
Lívia
represent the
Pimenta
same
representando la misma
Bonifácio,
institution,
institución,
por
Olivia
gentileza.
Silvia
Bonifacio, por
Pimenta
favor, Olivia
Fisioterapeuta,
Bonifacio.
pós-doutora
She's
em
a
postdoctora en
physiotherapist.
salud
She's a
pública
desenvolvimento
y
de
professor of
desarrollo
projetos.
de
public health
proyectos.
and
Seja bem-vinda
developer of
também
projects.
para estar
Bienvenida también
conosco
por estar con
Welcome.
nessa
nosotros
mesa.
en esta mesa.
A segunda
The
instituição
La
second
segunda
que vai
institución
representar também
que
nesta
that
mesa
we would
será
like to
é o
invite
complexo
to
hospitalar do
represent
trabalhador
this
da
table
Secretaria de Estado da Saúde do Estado do
is
Paraná.
the State of
Eu
Paraná
gostaria de convidar
Me
Secretariat
gustaría
of Health,
Fernanda
invitar
Bauenli.
Fernanda
Fernanda
Bauemi.
Bauenli.
Fernanda Bauenli
Fernanda
Fernanda
Lisi,
Bauemi.
Bauenli
espero
Luisi,
acertar
I
creo
aqui
hope
o
I got
sobrenome,
que
é
your
médica
has
name
dicho
right.
cierto.
coordenadora da
She's a
unidade de
Médica
doctor and
terapia
coordinadora
coordinator of
intensiva do
unidad
Hospital
de
intensive
do
terapia
therapy
intensiva
Trabalhador.
del Hospital
of
del
the
Trabajador.
Workers
Seja
Hospital.
bem-vinda,
Welcome,
Bienvenida,
Fernanda, ao
Fernanda.
seu
Fernanda,
lugar no
también para
palco.
tomar tu silla en la
Convidar
mesa.
também André
Also,
Invitar
Oshilio,
también
André
a André
Oshilio Ubet.
Uber,
He's
engenheiro, gerente de
engineer.
ingeniero, gerente
estatística e
de
He's the
informação
estadística,
statistics
do
información
complexo
en
manager
el
hospitalar,
of
também do
complejo
the
complexo
hospital
hospitalar
hospitalar
do trabalhador.
complex
del
of
trabajador.
the Workers Hospital.
Bem-vindo, André.
Welcome, André.
E a terceira
Bienvenido, André.
And the
instituição
third
que será representada
institution
também,
estará
estará
that will
representada
also be
nesta
represented
mesa,
in
é o
this
Hospital da
table
Criança de
is the
Brasília,
Children's
HC,
Hospital of
da Secretaria
Brasília,
de Estado da Saúde do
HCB,
Distrito
of
Federal.
the
E nós
Distrito
convidamos
Federal
Luciana de Freitas
Secretariat
Veloso
of
Monte,
Health,
Veloso Monte,
Fernanda
por favor.
Monte.
por favor.
Luciana é
Luciana,
professora da
sorry,
Faculdade de
de la
Luciana.
Medicina
Facultad
da
de
Universidade
She is a
Medicina de la
de
professor
Universidad
Brasília em
of
Católica de
Pediatria
Brasília
medicine
e
in the
coordenadora de
Catholic
Pediatria Pediátrica
coordenadora
do
de
University
HCB.
of
pediátrica
Brasília.
del
Seja bem-vinda também,
HB.
Luciana.
Welcome, Luciana.
HCB,
Muito
perdón.
bem, formada a
Okay,
Muy bien,
mesa,
now the
formada la
para a
table
mesa
is
condução dos
para conducir
trabalhos,
los
composed and we can
o
trabajos.
start
coordenador, o
Señor
senhor tem a palavra.
coordinador tiene la
this
palabra.
panel. You have the
Bom
floor.
dia a
Good
todos.
morning,
Buenos
everyone.
días a todos, todas.
Hoje com
Hoy
mais tempo
Today we
con más
have
tiempo
debate
more
para
para
conversa
el
time
do que
debate
for
charla
discussion.
que ayer por la tarde.
A gente é um grupo de
We
pesquisa
are a
enorme,
Grupo
research
de
group that is
investigación
huge
apoiados aí
and
pela OMS, pela
apoyados
multi-centric,
por
OPAS, pelo
OMS,
Ministério da Saúde,
supported
por cada uma
by
das nossas
by
instituições.
por cada una de
PAHO
nuestras
Hoje a
and
gente
the
vai
Ministry
debater
of
um
Health
pouquinho
and all the
sobre
institutions.
essa
And today we're
atendimento
going to discuss
especializado
the
pós-Covid.
specialized care
Cada
for
dos pontos que a gente foi
post-COVID.
Covid,
elencando aqui
cada uno de los
durante
puntos
esse
que
seminário e
During the
também
estamos
nos
tocando
dois
seminar
anos de
During these 2
parceria,
years of partnership,
foi dando mais corpo mesmo para o
we
grupo,
Foi dando
um,
más
engrandecendo mais
espacio
ainda
para
o
el grupo,
more
trabalho.
people in the group,
Espero hoje
and
aqueles
we
colegas
strengthen
também
our work.
colocarem as suas
And I
experiências para a
hope
gente
we
conseguir
can
avançar mais ainda nesse
advance
tema que é do
even more.
pós-Covid. Então, com a palavra aqui,
So now,
doutora Antônio Pazin Filho,
Dr.
doutora
Antônio
Lívia
Pazin Filho,
Bonifácio.
Dr. Lívia Bonifácio.
Alô. Bom dia a
Good morning,
todos. É um prazer
everyone.
estar
It's a
aqui e
pleasure
queria
to be
começar
here. I would
agradecendo o
like to
convite que nos
thank
foi
the
feito para participar
invitation
desse
to be
estudo.
here at the study.
Para a gente é uma
For
honra
us, it's an
poder
honor to
participar.
participate.
E a gente queria mostrar algumas
And
coisas
we
da
would like
fase
to
1
show
e da fase
about
2,
phase 1 and
da
phase
estratégia 1 e
2,
da estratégia
about
2.
strategy 1 and strategy 2.
Então, onde que eu aponto aqui? Qual que é? Aí, perdão. Como é que volta? Aqui. Bom, nosso
Well,
hospital
our
das
hospital
clínicas, ele é
is the
localizado em Ribeirão
Hospital das
Preto, no interior do estado de
Clínicas
São
in the
Paulo. É um
state of
hospital
São
de em
Paulo, in
torno
the
de
city of
1.000
Ribeirão
leitos
Preto. We have 1,000
e
beds,
responde por
and
uma região de
it
4 milhões
it
e
is in
meio
a
de
region
habitantes no interior
of
do estado de
four
São
and a
Paulo,
half million
no
inhabitants
nordeste do
in
estado
the
de São Paulo
northeast of the
e o
state of
sul
São
de Minas
Paulo and
Gerais.
the south of the state of Minas Gerais.
Nós tivemos aí
We had
cerca de, em
in
2021,
2021
73.271 confirmações e
73,271 confirmations of
1.996 óbitos, com
cases
uma
and
letalidade em
almost
torno de
2,000 deaths with a
2,7%
lethality of
na cidade de Ribeirão
2.7%
Preto,
in
né?
the city of Ribeirão
Em
Preto. In
2022, esse número foi de
2022, this number
141 mil
was more than
notificações e uma
141,000
letalidade de
notifications and
0,7%
the
e uma
mortality, the
cobertura
lethality of
vacinal contra a Covid que
0.7%
chegou
and a
a
vaccination
93%
coverage
na
against
primeira dose
COVID-19 that got
e
to 93% of
68%
the
na
first
terceira
doses
dose.
and
Isso ainda
80%, 87% with the
os
second
dados da quarta
doses.
dose ainda são um pouco
So
desanimadores.
for the fourth doses, the data is still
Então,
discouraging.
ele é um hospital de alta
So it is a
complexidade,
high complexity
referência
hospital.
terciária para o
It a
DRS-13. Nós
tertiary
somos responsáveis durante a fase
reference
Covid,
for
desde o início, por cerca de
13.
40
We
a
are
50% do
reference
atendimento
and we are
em
responsible
todos os casos
for about
terciários
40
dessa
to
região.
50% in
Então,
this
nossa
region.
instituição passou de
So our institution
cerca de
went
10% de
from
leitos de terapia
10%
intensiva, que
of
serviam
ICU
a tudo.
beds,
Nós abrimos
and we
80
have
leitos de terapia
opened
intensiva
80
só para Covid
ICU
durante
beds
todo
just
esse
for
período.
COVID during this period.
Nós tivemos aí números, nós tivemos a felicidade de ter o
We've had
RT-PCR dentro do
the
hospital,
happiness to
por causa de
have
ser
the
uma
PCR test
instituição
in the
forte
hospital
em pesquisa,
because
então
we are a
nós não
strong
dependemos e
institution
pudemos
related to
avaliar
research, so we
praticamente
could
tudo.
evaluate
Temos
everything.
vários dados,
We've
alguns
had
sobre
a lot
a
of data,
caracterização
especially
do
about the
tipo de variável,
characterization
mas
of the
eles
type
ainda não
of
estão no
variant,
prontuário
but
médico,
they are not
são
in the medical
dados
reports.
de
These
experimentação,
data,
mas podem ser agregados posteriormente.
these data come
Número
from
total de
the
Covid que a gente
experience,
teve
but
aqui
we can aggregate
casos
later.
positivos foi
So about the
3.300
positive
em
cases,
ano e
we had
4.700 no outro,
more than
e o
4,000
atendimento
in 1
ambulatorial de
year,
2.300
and
para
we had an
3.400.
increase also in the primary care
Aqui alguns dados
unit.
gerais de atendimentos de
Some
enfermaria,
cases for the
CTI,
infirmary
os
and
óbitos que
also
nós tivemos, a nossa
ICU.
taxa de mortalidade,
Our
isso eu
mortality
vou
rate
apresentar com
is
mais
also
detalhes
there.
depois. Fundamental para a
It
nossa
is
estrutura,
fundamental
esses
for our
dados
structure
aqui, a gente, para
these
combater o
data
Covid, a
to
gente formou
fight COVID. And we
gabinete de
have
crise
formed a
reunido
crisis
diariamente às 8 horas da
center.
manhã, todos
We
os dias,
gather
durante
everybody every
todas as
day
fases do Covid,
to discuss
que eu
all the
coordenava,
phases of
onde
COVID.
todas as nossas áreas
And all of our
reportavam
areas,
para a gente
they
quantos
reported to
casos
us
nós
how many
tínhamos suspeitos
cases,
e quantos já tinham
how
sido
many
confirmados.
suspected and
Esse
confirmed
aqui é o
cases there
resultado
were.
dos nossos
So this
casos
is the
totais.
result of our total
Vocês veem a
cases.
diferença entre as
So you
três
can
ondas
see
aí
the
que nós
differences of the
tivemos.
3 waves that we
E
had.
esse dado aqui,
And
ele é um
this
dado que eu acho bastante
This
interessante, que são só os de
slide
terapia
is
intensiva
about the
diário. Isso não é
ICU
uma coisa que a gente consegue
cases.
tirar do banco de dados,
This
que
is
foram
something that we cannot
que
extract
foi
from
da
the
estratégia que a gente está colocando.
database.
Mas qual foi
But
o dia a dia do gestor
this
para
represents
poder
the daily
gerar
life of the
uma
manager
resposta
to
do que
generate
está
a
acontecendo?
response to what was
E o
happening.
que vocês veem
And
nessa
what
linha
you
negra
see in this
é o
black
número de
line
leitos de
is the
terapia
number
intensiva que nós
of
tivemos
beds
que
of
abrir.
ICU that we
Então,
had
no
to open.
começo, no
So in the
primeiro ano,
beginning,
né,
the first year
2020,
in
nós abrimos
2020,
muito mais
we've
capacidade do
opened
que nós
more
fomos
capacity
demandados, porque a
than
gente
we
estava com
got
pânico.
demanded because we
Uma
were in
coisa que a
panic.
gente não pode esquecer dessa
Something that
pandemia
we
é que nós
cannot forget
vivemos
about the
pânico
pandemic
entre os
is that
profissionais de saúde.
we
Só
were
quem
in
estava ali na
panic.
ponta
We
teve
specialists
noção clara do que foi
we
o
were in panic.
pânico que nós vivenciamos
We
entrando nessa
have
situação.
experienced that.
E depois disso houve um
And then after
aprendizado
that, we
e
learned,
que essa estratégia do
and
gabinete de
this
crise ela
strategy
permitiu que a
for
gente
this
fosse abrindo e
crisis
fechando
center,
leitos de acordo com
we
a
could
necessidade que a
experience and we
gente
could
tinha
open and
e
close ICU
mensurando
beds. We
os
were
óbitos, as
measuring
coisas
the
que
number
estavam
of deaths
acontecendo.
that were
Então,
happening.
isso permitindo a
So
gente
this
também
allowed
buscar
us
dinheiro e
to
coisas
seek for
nesse sentido
money
de
and
e profissionais de saúde
resources
nesse
and health
processo todo.
professionals in this sense.
E isso aqui é a taxa de
This
ocupação
is
dos
the
leitos de CTI.
daily
Então, vocês
occupation
observam que na
rate for
segunda
the
onda, a
ICU.
nossa
So
taxa
as
de
you can see,
ocupação
in the
quase por
second wave,
9 meses foi de
it
100%
was
dos leitos
almost
abertos.
100%
Para
of the ICU
78 leitos,
beds for the
100%
second
ocupado.
wave.
Então, esse é um dado de dia a
So
dia,
this
de
is
séries
something
temporais, que
that
talvez seja uma
is for
coisa
daily.
interessante da gente pensar
This
na
is something
estratégia, porque
daily, and we
isso
have to
sim
think about the
traz uma informação
strategy,
para o gestor
because
em
this
tempo
brings an
real do
information
que ele
to the
precisa
manager in
resolver
real
e que
time
ele
to
precisa
see
tomar uma
what
decisão
he
estratégica,
has to
né?
do, what decisions he has to
Bom,
make.
a idade média dos nossos
The
pacientes foi em
average
torno de
rate of our
52
patients
anos, a
was
maioria
about
de sexo
52%,
masculino,
52
maioria de
years old, I'm
etnia
sorry.
branca.
Most of them
Etnia é
were
um problema no
male,
nosso mundo, no
and
nosso país aí,
they
né,
were
em termos de
white.
caracterização. A pequena parte da
A
nossa
small part
amostra de
of our
gestantes foi
sample
pequena, então acho que
was
isso vai
composed
compor
of
com o
pregnant
grupo,
women.
mas, né?
It was
E
a small sample.
A maior parte das
And
internações
most
hospitalares da
of
nossa
the
amostra são adquiridas
commitments
da unidade
in
de
the
emergência, que era a porta de
ICU,
entrada
which was the entry
do nossos
door
pacientes
of
no
our
complexo.
patients,
Mas a gente também
was
exerceu durante a
about
pandemia, nós somos o
2.04%.
hospital no Brasil
But
que
we
mais
also
fez telemedicina.
we were also
Nós
the
criamos uma
hospital
estratégia de
that most
telemedicina
worked with
e
telemedicine.
exercemos telemedicina para
And
cuidar
we
dos
have
pacientes que não podiam
done
vir no
that for
hospital
patients
e
who could
também
not
a
go to the
estratégia de
hospital, and
telemedicina
also
para
strategies of
criar os
telemedicine to
pacientes
screen
que
the
não
patients
que estavam sendo
that
solicitados vagas para a gente dentro do
requested
hospital.
for vacancies in our
Então a gente
hospital.
conseguiu,
So we
isso
could,
talvez tenha
maybe
enviesado
this
pouco mais a
had
nossa
given a
amostra, porque já
bias to
são
our
de pacientes
samples
terciários,
because the
mas a
tertiary
gente garantiu que
patients were
seriam
higher,
pacientes terciários,
but we
para
made
não terem que
sure
vir para
that
cá
they
no
were
hospital e
tertiary
depois não vir. Então
patients,
esse dado
so
de
they would
telemedicina nós
come here.
temos, se
So
quiserem
this
acrescentar
data,
na plataforma,
these
eu acho
data, we have
interessante,
this,
talvez fosse uma
and
sugestão aí
if we want to
para
add
frente.
this to the platform, maybe this is a
Comorbidades
suggestion.
prévias foram prevalentes,
Previous
eu tenho uma tabela para
comorbidities
mostrar
were
isso para
also
vocês,
frequent.
acho que
I have a
repete um pouco o que
table.
já foi
Maybe we
colocado.
are
A
repeating
fase
what
aguda
was
foi
said.
tosse, dispneia, fadiga e
The
mialgia, que não muda muito
acute
do que a gente já
phase
conhece da
was
história.
cough,
Os corticoides
fatigue,
foram
and
muito
myalgia,
utilizados e foram
and
salvadores. Eu mesmo tive um caso na família
corticosteroids
que
were
só
very
não foi por tudo porque
used.
começou o
They were
corticoide
very
na
frequent,
dose certa, na
and they
hora
started
certa,
with the
né?
right doses at the right time.
E os anticoagulantes e o
And
suporte suplementar. E os dados
anticoagulants
de
also were
antibiótico
very
eu não tive tempo
important.
de pormenorizar, mas
And
eles
we
refletem o
have
que
other
foi apresentado
data that
ontem, de
represent
uso,
and reflect
que eu
what
também
was
concordo
used,
fora
and I agree
do
with the
recomendado.
use.
A maior parte nós
Most
utilizamos a
of
escala
this,
que foi proposta aí do AVPU,
most of what we
né, da
propose
admissão
in
da
the
maior parte
AVPU scale,
dos casos de alerta,
we used in
53,5.
the alert cases
Nós
about
tivemos uma internação de
53.5%.
69%,
We had a
a maior
commitment,
parte aí.
hospitalization
E
of
os desfechos foram alto
69.9%,
hospitalar, tivemos em torno de
and we had
30% de
about
óbitos
30% of
gerais.
death.
Aqui esse gráfico ele
In this
mostra
graph,
de uma maneira mais
it
adequada,
is
eu acho, nós
showing
tivemos 4.596 notificados no total,
4,596
excluídos
notifications of cases,
156 por
and
dados faltantes.
156
Esses já são
were
os dados que nós
excluded.
mandamos
This is already the
para a
data that we
plataforma.
have sent to the platform.
Nós tivemos dos casos
We
confirmados,
had
55%, 45%
2,000
foram
non-confirmed
descartados. E eu
cases and
destaco aqui a importância de ter o
2,448
recurso
confirmed
em tempo
cases.
real. Nós tínhamos o
And the
PCR, isso permitiu
real
que nós
life resource
atendêssemos
is
muito
very
mais, porque a
important
gente tinha
because this
como
allowed
tirar
us for us to
o paciente
serve
do
even more.
isolamento.
We could remove the
E
patient
eu
from
sei que isso foi
isolation.
uma dificuldade para
And
vários
this
hospitais
was something
brasileiros.
that was very
E
difficult for
quando a gente
many
observa
institutions in
aqui,
Brazil. And
dos
when we
casos
observe here,
confirmados,
out of the cases that were
69%
confirmed,
deles foram admitidos em
69%
CTI,
were
mostrando a nossa
admitted
gravidade,
to
nosso
ICUs,
esforço. E
showing the
dos óbitos,
seriousness
nós
of this
tivemos
disease.
40,5%
And also
de óbitos
death,
totais
we
dos pacientes
had
que foram para CTI. Enquanto que
40.5%.
aqueles que foram admitidos
So
para
the ones
CTI
that
em
were
casos não confirmados, que são casos
confirmed
graves,
to
e
the
isso foi uma outra coisa
ICU,
que a gente notou
and with
também
that
no
we didn't
sistema,
have
que houve
serious
uma
cases.
falha do sistema
So
de
we
regulação.
noticed that there was a flaw in the system. And in a very clear and adequate way, I want to say this. We are a tertiary hospital that is the organizer of a system, but the system around us, the primary and secondary health, was not prepared to deal with what was happening. And through this telemedicine structure, we try to organize, because a lot of people that were at the end, they wouldn't follow protocol. It was available, and it was a guideline to all of us in the region. And we called every day. How's the patient today? What we have to do? How can we change that? So this is a point, but most of this mortality rate that got in the ICU, it is very easy when the in the doctor's field, when they found a patient that couldn't find if it was COVID or not, he would call this patient and he would say that it had COVID. So this is something that maybe we have to reflect in the future, because our regulation system is like this. When there is a serious patient, an intubated patient, if it said it was COVID, it got solved, and if not, it would bring them to us. So this is something that we have to have registered. We have to think about this. We have to think about our whole health system. Now we split it on some semesters.
And they're going to be great customers. Now I see Livia to come back. I'm sorry if I am. Good morning, everyone. I'm going to present strategy 2, which is a segment for patients post-COVID. This I've been talked about the data in the platform. We analyzed 227 patients that were followed into our place in a post-acute stage. I'm going to explain a little bit later the specificity of this place. The majority of a sample was male. about the same age. They were white, Caucasian. So we have these datas that each professional of health is going to sign in a different way. But you look at health and height. Obesity is a very important comorbidity. And scholar, we also considered schooling and education. So previous comorbidity was the majority what we saw from other data in the literature, and complication that we saw in our sample during acute COVID time was in the SID and urinary tract infection and other infections. Quickly to speak about the ambulatorium post-COVID, it was an ambulatorium that we, not us, the professors actually worked on this. Professor Benedito and other ones like Benedito Alves da Fonseca is also part of it, Valdes, Roberto Bolela. They idealized in order to follow up with the patients post-COVID. So initially, we followed basically all the professionals in health that were in the front line and began to talk about persistent symptoms. So we started this ambulatorium in May 2020, and we were structuring throughout time. So here we made a pattern in how we attended each of them, and it was very similar to what OMS suggests in April. We would follow the patients in the first days and then 15 days after the acute phase, and throughout time along 3 months and 6 months and 1 year of follow-up. In each follow-up, when necessary, to do a clinical exam, physical, according to the complaint of the patient, and also image studies. And MINC and ambulatory, we had special in other areas, other sectors that were important: physical therapy, in the respiratory part and the muscle skeletal part. Many patients had different limitations. Most strong cases with eye doctors, phonoaudiology, ear, nose, and throat doctors, things related to swallowing, immunologist, biochemical analysis, and cardiology, doing the special research throughout time. So the objective was to follow these patients having the survival that survived post-COVID, and throughout time, what are the repercussions, especially psychological, social, and difficulty of the patients post-COVID and going back to work. That was very important. All the demands and limitations. And at the time, we had a boom. It was going to the ambulatory once a week. During the morning, we would receive about 20 patients. In the worst phase, imagine 20 patients with very few people to help. It was very tough, but we had to follow up with these patients and thinking about vaccination. And nowadays we have about 6 to 10 patients per month. It's more manageable. And here we have our contribution to the scientific literature. The first article, it was the first case report talking about reinfection cases. It was evaluated in June 2020, published in September 2020, right in the beginning. We didn't think this was possible. But here all the repercussions from the ophthalmology section, looking at those as a postdoctorate. I do not want to extend too much. This is some images that were shown at the time. We were invited for several interviews, participated in lives in order for us to learn what were the symptoms and and post-infection, and if they could leave behind some issues. And I'm open for questions at the end. Thank you, Olivia. And I'm going to pass immediately to Fernanda. And so you can have your speech. And at the end, we're going to have a debate that I find very interesting with all the experiences. So you can share your experiences. First of all, I would like to wish everyone present my good morning. Is it possible to put our presentation up? We came here to tell the story of how the pandemic worked at the Workers' Complex Hospital. It is in Curitiba, in Paraná. It was a reference hospital during COVID time. We were composed by 6 hospitals. The first hospital was a worker hospital. The other ones were incorporated. The direction of the management of the hospital was in part the rehab hospital, and during pandemic was the exclusive one for COVID pandemic. The integrated hospital was Soro Labial, and the regional one, Ucreide, also in Curitiba. Nowadays, the hospital complex of workers has about 466 active beds. From these beds, 80 are from ICU, 366 are regular, 10 are for newborn, maternity, for intensive care for neonatal. During pandemic, the worker hospital had at most 22 bed for COVID, and the hospital for rehab had 68, Osvaldo Cruz had 10, and São Sebastião 10. These are on different dates. In this chart, we see the beginning of the pandemic when we got the first cases in February, but it started in March. We had the first curve and the highlight in 2021. In January 2021, the first vaccine in Paraná was given at the Workers' Hospital 18th of January, and one of the nurses that worked in the front line. Pandemic started. We had a peak in July 2021 and a new peak in the beginning of 2022. In total, we received 11,122 cases, and there were 4,000 cases in 2020, 5,000 in 2021, and about 1,000 in 22. We reached the peak of 255 beds of COVID daily, we proposed the management of the hospital to monitor all the way from sign in until they've been released, all of those who have suspicion of COVID. And we wanted to see how it ended, how everything that happened, and all the further information so that the hospital could, the same way, monitor daily and follow up every day how the pandemic was working inside the institution. We were monitoring mechanical ventilation in case the patient had already been confirmed. We call them suspect if they was still negative, and so that generated a very strong and faithful basis for the hospital. As soon as vaccination started, we also monitored if patient had already taken the first, second, or third dose. That was monitored daily and had been given to the management of the hospital daily as well. Aside from all those collected information, there was a project, and the project was with the objective of mining the data so that we could get more information. In order to unify, we wanted to unify all the data bank inside the hospital and transform it into just one data bank with the evolution and the prescription and everything that was requested for the patient to do by the doctors, and all those were monitored. One of the steps to mine this was to select this database that were utilized from different systems in order to launch the evolution and how the diagnosis and the image diagnosis. Later, we did a very strong partnership with the medical team and discipline and the education team, and we talked about each question inside the research, and that came up. We had a very positive result with very easy to be accepted for everyone, and we were able to see each question inside each module. Later on, we implemented all this with a positive and a negative, and those that we were questioning, we would have one person to evaluate the chart, the patient's chart, and then give a result. And with these results, we generated an algorithm, and that's the basis that generated the project. So here's a project how the mining was done. For example, so we looked when patient has a certain problem, like a breathing problem, we looked at the positive and the negative according to the answers. We put yes, no on the chart. And if the algorithm wasn't sure, this would fall into a verification category. It's about 249,000. According to, it would fall into certain place. In order to facilitate this, we could audit everything. We could audit the words, the keywords. We had 30 characters to the left, 30 to the right, and only audit the text that was necessary for you to audit and understand the context. Inside these evolutions, what happens? Many patients had more than one evolution. Sometimes they had 81 evolutions or 84, but 3 of them would be positive. So depending on the question, the questionnaire and the question that was made, you had priority of answer. If the answer was yes, and if the priority was say no, or if the priority was to say yes or no. So depending on the answers, we had a chart that would prioritize the way of answering the questionnaire. and that generated a result, a significant result inside the mining of results. Well, I'm gonna now go and speak now about the strategy that Andre mentioned. It's always very valid, where we did this partnership in order to structure these keywords. And in order to do this search, everyone had some difficulty because following to fill in this variable is we were never free of having issues with that sometimes. So following our every time we could see a new patient and help the secretary, the workers hospital, which is this main one in town, was working together with the rehab hospital. They had soon started it, and is the one which strengthened us a lot in the ambulatory post-COVID. In the beginning, this hospital was entirely transformed into basically intensive therapy. We have several beds, and we were able to accept them in infirmary. And the spaces of all the units of the complex, we were able to check if we had oxygen also, and transform those beds into ICU. The same way we mapped in how what we had was necessary or not necessary, and from there make a plan of action. The only thing we had a problem was cash, money. We were trying to check daily everything that our colleagues presented. We were able to see how many ventilators and bed, and we had to see if we had how many of the workers were even not able to show up because they had maybe COVID. So we had a lot of people sick, and that was a problem for us. And so we were daily ready to give sometimes people discharge. Daily, together with the coordinator of the pharmacy, we were able to map the use of special indication, and then they were able to separate by unity and by ICU, and that helped a lot. So when that called attention, because some ICU were using more than another one, in that way, patients that were more in a severe case, sometimes they had a certain, with a doctor with less experience.
And this was according to the doctor's criteria, because sometimes they would use medicine. So this contact with the pharmacy was very important, including the stocks, what we had to adjust in our prescriptions, sedation prescriptions, what we had to be reviewed. Based on all of this, so we had some existing protocols that end up being used by the state secretariat, and also some protocols that were needed in case of lack of inputs. So we had medicine that was not very used, also accessory medications in case we had to do some rationing, including inputs like infusion bombs. So we have designed these protocols that ended up being standardized by the secretary. Here is the quantity of beds that were active and that we had every month. And one thing that we can observe that most of the time we had more numbers for the ICU than in the infirmary. So the proportion was basically the same. We have served patients that were high complex patients, and that needed attention for 24 hours, and we underwent through the same difficulties. It doesn't matter what the patient has. If it is a COVID suspect, it would have an ICU beds, but this was very difficult to allocate the patients in the units. We had units that, of course, were not separated, so we had to make sure that this patient had COVID, so we didn't have a contamination in the hospital. And something that helped us and difficult to the strategy It was the rehabilitation because our beds were in the infirmary 2 by 2. So we classified that by a low suspicion, high suspicion to avoid contamination. Out of these 68 beds, 62 at least they were in 2 by 2 bedrooms, and this was what we had to do to avoid contamination. About mortality, it is something very similar to what we've seen before. We had serious patients and we had a global mortality of 21% in the ICUs. Of course, in months, we had very bad numbers. About the half of the year of 2021, we had high mortality rates. The patients, they would come very late, terminal state, with 10 days of intubation, and some units they had a mortality rate of more than 50%. Of course, we diluted that, but analyzing everything, and although we had an overload, we had monthly meetings for the ICUs, and we could maintain that in a lighter way, but we try to understand and explain to our multidisciplinary teams that the number of deaths and overload, so the feeling was that the patients were dying in spite of everything of what we were doing. So we had to talk to their hospitals, what they had seen internationally of data, to take a look at what we were doing. And we had some very bad months, and we understand that we did that in the right way. And of course the difficulties were regarding assistance and using of antibiotics and other bacteria type R. And we have a graph by age rate according to death, and we can see a clear change with vaccination. We started with the health professionals, but then we started with the age rates, the more advanced ones, and we see an abrupt drop, especially among people in the age rate of 60. And then we can see the patients of 50, 59 years old. As soon as they were vaccinated, also this mortality tend to drop, and this changed the destination, changed the destiny of the people that were sick. In the first phase, were more than 4,000 patients. The patients, they were 50, 59, 60, 69 years old. We saw the same comorbidities. It was presented before, and also we've seen male patients. About post-COVID, we had some patients in July of 21. They were few, but they were the first ones that we had to underwent treatment in our hospital. So we have a structure, we have physiotherapy, we have a pool. So in the beginning of the pandemic, it was completely closed because the patient was taking on the serious patients, and we didn't have health professionals to do this kind of treatment, and we didn't understand that would be necessary. And then we started to make the structure, and this was how we did that, and we defined what is syndrome post-COVID and not, what is long COVID, what are the symptoms. So we needed to define this a little better. These were the patients that we had. We evaluated more than 4,000 evolutions. We had 22 evolutions per patient, and the average time of follow-up was 193 days until they were discharged from the primary healthcare unit. And of course, the physiotherapy was the most sought therapy, also occupational therapy, the infirmary, along with the infirmary technicians, were very important as well, because many patients had tracheostomy, injuries, lesions, so they would return to the infirmary, so they would learn how to take care of themselves. And we also had neurologists, cardiologists, infectologists, ophthalmologists. So these were structured labs. We could follow up on these patients very specifically, and also otorhinolaryngologists because they were laid down for a long time, and we had a lot of cases, and we needed to follow up on these patients. And also we had the primary healthcare units that were multidisciplinaries for some patients. The treatment doesn't happen separately. They do it in an integrated way in the same room with the patient. So these conducts together, they see the best plan for the patient. The fact that the hospital has these primary care units, of course we had to adapt a lot for these patients, but this was a facilitator. So this is what we have at the moment. Today, this demand has dropped immensely because of the complexity and seriousness of the cases. The trainment in January and February of 2020, where we know that these waves would come and the panic was already installed because Italy was seeing a lot of bad days, and we were talking to all the other professionals there. We saw that we needed the trainments with multidisciplinary teams, infirmary, and it has taught a lot, especially infirmary technicians. The multidisciplinarity, this integration of the team was very important. During moments that we didn't have equipment, some sewers that were unemployed, they were hired to make tissue masks, and they were destined, the inputs were destined, and we didn't know that if we were going to have enough masks, including to work. So the union, this purpose is important, this integration is very important, the team was very nice, and this has strengthened us to overcome the challenges. We are a complex that integrates only public hospitals. It's 100% public hospitals. We don't take on private cases, and this is very structured. And also the vaccination was decisive to change what we were undergoing, and this is very important for us so we don't go back to the situation, or that situation gets worse. We would like to thank all the managers of the hospital complex and that were our partners during the pandemic. And also we would like to thank the invitation to be here and participate in the project with everybody, and also with Who and Pajo, and to have the opportunity to share what we have seen. And it is very important to be a difference in the lives of the others. When we had this proposal to collect data, I asked, oh my God, how can we look at this? Because although we are part of research, it is very different when we have to look back, and this partnership was very important, and we could generate a lot of data. Thank you very much. Thank you, Fernando and André. It is very interesting. Now I'm going to give the floor to Luciana to talk about the Hospital of Brasília. Good morning. Thank you, everyone. Can you put my presentation on the screen, please? While they do that, I would like to greet the table, greet all of you who are present and the people that are online. And I would like to thank you for your invitation to be here talking about the results in the Children's Hospital of Brasília. I am a pediatrician, pulmonologist of the hospital, and I was part also of a clinical research, and I'm going to present data from the global platform and also from this clinical research. I think it's another. And here we show the slides are a little dense and we have reduced them because of the time. And I would like to thank Hu and Pahu, not just because of the invitation to participate in this platform, but for the great work during the pandemic. I also would like to thank, while we are waiting for the slides, I would like to thank the team from the Children's Hospital of Brasilia, the research team, the directors, and also for the effort and dedication. I would like to thank all the patients, the families, and also the Porto Alegre Hospital that is helping us to extract this data, the researchers, the frontline workers, and also we'd like to give our solidarity to COVID patients and COVID victims. So this hospital is a public hospital. It's 100% within the SUS, and it serves patients with their under 18 years old. So the magnitude was lower than what we have seen in the adults. The level of attention is tertiary, so we serve patients that have complex health situations. Patients, most of the time, they have a comorbidity, and we have 200 beds of hospital in the hospital. We have clinical and chirurgic. What was the strategy during the pandemic? We had the preparation, and at the same time we were preparing our patients and our collaborators, the families. We were providing trainment. We had some guidelines, and we had the technical chamber of COVID that guided our conduct during the pandemic. Also some guidelines from the hospital. We had some strategies to improve diagnostics, so we implemented the RT-PCR, and we decreased the load of the central lab, and also making it easier for us to diagnose the disease and having rapid results. Less than 24 hours we had the results, and we could do the management of the beds, isolation, to decrease the dissemination of the COVID in the hospital, because we tested everybody. All the patients that checked in the hospital were tested. We tested the people that were with the patients and also the workers of the hospital. So this has helped a lot with the management of beds and the management of the pandemic. Also, we had the lab LACEN that has enabled us to do that, and we had the genomic management. We had weekly reports in the hospital about the COVID cases, also for the people that were in the hospital and the workers at the hospital. There was also the telemedicine. We had a lot of experience. I think this is worth mentioning in the platform. This is important data. we have expanded the number of ICU beds for COVID-19, and we had a contribution to open 10 beds for adults. We opened a specific area for adults because the system was very saturated, and we hired um, specialists to help that in this situation, in this critical situation for the adults that were in very critical condition. This is the number of examinations that we did. And now I'm going to show you a little bit of the results, the clinical part of the research, and what data we could gather. The first case, we know that the pandemic was declared on May 2020, and we started to have community transmission cases. Our first case was in May 2020, and at that moment we were organizing ourselves to do a clinical research protocol to understand what was the situation of our patients, especially those that had chronic disease in relation to COVID-19. And then we had a research protocol that started officially after the ethical committee started in July 2020, and we included patients during 4 months in the phase of the cases. We follow up on the patients from the point of view clinical and physiological. And after that, we started in May 2022 with the partnership of the global platform of WHO. We started extracting the data, and I'm showing you here these results. Up to May 2022, we had 465 cases of COVID-19. So I'm going to show you the data from the platform, and we are still extracting, we're still trying to better extract these data and analyze them. And I'm going to show you also the information about the research, and we hope that we can put this in the platform, not just about 2020 but 2021 and 2022. So the platform, I am here representing the three main researchers, Evelyn, Ivo, and Cristiane. They were responsible for the partnership alongside with PAHO and WHO. And I also would like to thank the people at the hospital in Porto Alegre, because we still have some data that is missing, and we are very happy to deliver this data to everybody. So I would like to remind you that these are people that were hospitalized, and also they had chronic disease, and they were pediatric patients. We had some hospitalizations for adults. We also have some data from that, but the most frequent data are from the patients that were pediatric patients, so up to 3 years old. Here we show in the graph the distribution according to age rate. According to the seriousness of the disease, we did a pre-screening, so not just the ICU cases that were contemplated. So we had chemotherapy, we had the flu. So most of the cases, 60%, they were light cases that you can see in the right side in green, male and female. We had moderate cases in purple, and we had serious cases in red. Also the virus syndrome, not all cases that we collect are here, but in the pediatrics we had people that were hospitalized by serious virus disease, and the lab was so overworked, and we couldn't do some screening. So these other viruses were detected, and they didn't have any different influences in the COVID cases to see if there was any factors related. From now on, I'm going to show the data from the research, And this clinical research that we conducted was in the beginning of the pandemic. We recruited the cases in the first 4 months in 2020 when the pandemic started, and then we were following up on the cases for 1 year, and we had very robust cases from the clinical point of view. This is a research. I'm going to talk because of the time. I'm sorry. They are going to put the presentation here, and it was something that we observed. We didn't intervene. It was descriptive in the beginning, and then we followed up on the patients up to 18 years old. I'm going to show the data, but I have to wait a little bit because I need to see. And then how did we conduct the research? After the patient was checked in, this is the one, yeah. We recruited those cases during the 4 initial months. We collected the RT-PCR in the hospitalization of those cases, independently of the cause. And after that, we followed up on some cases in the D7, D14, after 60 days, after 90 days, up to a year. We followed up on these patients to see the behavior. Yes. Yes, about the comorbidities, I think we can pass that. Okay, this is the research that I said. We wanted to understand the behavior of these patients regarding COVID. And we wanted to answer those questions, especially the chronic disease patients. You can pass because I already talked about that. I was explaining that we did the serology and the clinical follow-up up to a year. And then the results. Can you pass one more? Okay. In this period of 4 months, from July to October 2020, we had 122 patients that accepted to participate in this research. They were hospitalized in our hospital, and out of these patients, almost 15% of all the cases in the hospital, they had COVID-19. They were positive for COVID-19. Other patients, so they had other diagnostics. There was no vaccination at the time for the pediatrics patients, and the serology has helped us in this diagnostic. You can go to the next slide. And we had 68% of chronic disease. Half of them had some immunosuppression case. The flu syndrome was 35%. The SARS was 20% of our cases, with average rate of 3 years. 66% of they had comorbidities, and 91% were admitted to the ICUs. MISC, we had 17% of the cases. They were all hospitalized. That's why our rate is high. And we also have an average rate of 9 years old. And most of them were... And we had an important... Most of them were hygids, and most of them, they got admitted because of surgery, and they were COVID-19 positive. And this has helped us in the management of beds and also to prevent dissemination of this infection. We've had critical cases, although the pediatrics patients are less affected, but we've had 30% of critical cases, and 48% of this had to be intubated. 48% of them had comorbidities. The main symptoms that are in this table, out of the patients that had clinical symptoms, most of them had fever, vomit, and cough. And the duration of the symptoms, at least for half of the cases, they had symptoms for 1 to 3 days before hospitalization. The main comorbidities in the study are shown there: neoplasia, hematologic disease, pneumopathies. And the people that were with the patients, they usually children, the parents of the children, most of them were also infected. Most of them were didn't have symptoms, and this shows the importance to be tested at the hospital. Okay, now I have here the ventilation support of this specific study, that they have a nasal catheter. And what they said, the use of antibiotics, about 38% of the cases, corticoid. We didn't have protocols that were set in this phase, so we were learning throughout time, and we were doing at the same time. We had also infections, and we had to use AAS. We didn't have randomic trials, so we didn't use any of the drugs that were experimental at the time. And we had protocols from the hospital and from the health system. Now I'm going to talk about the evolution post-COVID throughout 1 year. Most of the cases were follow-up on the primary healthcare units, and they are followed up on the clinics. In the regular clinics, there was not a specific lab, because the number was much lesser than the adults. So we had one death. It was an SRAG. Next one. But all of them, so you can see that in general, these children, we evaluated about SRAG in Minsk, and we were calling these patients, and also we would collect serology. So the data that we have show that the patients had a good development. We had one case that needed VNI, but he also had a neurologic disease. I think this can also have impacted, but he needed the VNI after the discharge. We had 3 cases that needed medication because of the COVID-19. They needed medication for a while, and some patients were hospitalized again, but we didn't associate with COVID-19. It was because of community pneumonics, or we didn't have anything serious after 1 year. And the image exams, we didn't have an intervention protocol. Well, we didn't say we had to do a CT scan at a certain point, so this was free. And also we avoid radiation for children, but some of them had some exams after 9 months, and we can see here that it was completely recovered, and we didn't think it was necessary to repeat these exams after a while. And I'm going to show you the MISC. There are 4 squares, and most of them we followed up on the patients, and there was the rheumatology and other clinics. There was no death in this case of the study, and most of them has evolved. We had some situations where the symptoms persisted up to a year. We had a situation that they have muscle weakness. There was this case, but in general, most of them have recovered well. Some of them used continuous treatment for at least 6 years after discharge, and some hospitalizations that were not related to MISC. For the cardiovascular exams, half of the cases they remained with alterations for at least 7 months after discharge. You can go to the next one. And after that, we have the serology data. We've had 85% of our sample, they had some kind of serology for a year because we had many difficulties to collect during the periods, and the patient was not always at the hospital, couldn't come back, so we couldn't collect everything. But the ones that we could do it, we had titrations that reached about 60, their maximum value after 60 days. That's the top picture, and we can see the serology curve, and we had a maximum titration after 60 days of hospitalization. And most of these had antibodies after a year after the initial infection. And out of the patients that we collected, they had serology that were positive, the total antibodies at the time. And when we analyzed the serology after a year, the children that had chronic disease or were immunocompromised, they had a higher chance to have the serology compromise when we compare to other critical patients. So there was this difference throughout a year. Most of the patients were not vaccinated yet, so we could have an idea of these titrations.
And on the right below, we have in blue the patients who have chronic diseases. They're a little smaller, and the patients who didn't have chronic in green, and it was a little larger. So, but in general, most of them had reactant serology in the situation. You can go to the next, please. We're almost over. So, the final conclusion of the studies: most of the patients with infections by SARS-CoV-2 submitted in the ICU during during their hospitalization and post-COVID, according to the notification of the WHO, we had 465 hospitalized cases and 30 deaths. With those 30 deaths and with wide testing for these cases, we were able to quickly detect in these cases and favoring detection and control of the infection and control of beds. Remembering we had 22% of asymptomatic cases. Next. Except for the cases of the severe acute respiratory syndrome, we also, except in those cases, those presented comorbidity, and in spite though 1/3 of those cases were needing or in need of intensive care. Most of them evolved satisfactory throughout 1 year, even those who had chronic diseases and are complex. That was a study of 2020. Okay, in the study of 2020, most of the patients that presented antibodies for and that were detected for the virus, they were still having a follow-up for a whole year. And now the patients who had critical COVID had more. At the end, the challenges that we learned and how we improved the Hospital of Children, like it was shared with our colleagues, the same way I managed how to deal with COVID, we were producing data and understanding better and reflecting over it. So it's very important this group of collaborating, all those of you who are here present. And finally, I would like to, I believe I've said all this. We have a picture of the telemedicine helping our patients. There was a very interesting experience. Finally, I would like to talk about producing this information through COVID. It's extremely important to extract data. However, it's very complex and dense. We need a lot of people working on it. That's why the technique of artificial intelligence is very important, so we can have these data and improve our data. We still have a lot of information that is still need to be. We need to improve in how to relay that information in our hospital. And I want to thank everyone so much. If you want to go to the next slide right here, the last one is I'm happy to be here, all of us together. I would like to thank our team. If you'd like to visit our hospital, it has their open doors. Thank you very much. Thank you very much, Dr. Luciana, for your brilliant presentation. We went a little bit over the time, but the presentations were very rich in many different situations. There have been put that's going together with the global platform. Those will go beyond. Some have put very interesting facts, like how you set up the beds in hospital in crisis. This is a group to be explored. And how did each institution organize that? How we have the capacity to help and assist. Sometimes we had difficult times, but we all collaborated. That's also learning curve. There's also a learning curve on this. As far as innovation, there were several points we had innovation in a matter of organization. We had to help the patient when they came in, and then, was this right or not? Let's try again. Just this way of changing how to do things. It's an interesting product. Sometimes we had to use 3D. Sometimes we lacked ventilators kit, and that was an interesting experience. How industry see the hospitals and how we dealt with all this. Also, the fact that we're doing research at the same time as we're rushing to assist. So we're trying to decide who's going to help, who's going to do the research, and who's going to do what at the same time. And managing this process is also very rich. It goes beyond of what we normally do. And this is a web of collaboration and a team of help, and very rich. I think it's very amazing, and I'm happy to be here with learning all this here with you. The way it's structured. Well, I'm gonna see what we're gonna do now. A question: how do you see the future of how keep going and developing all this? Because obviously, when we were in the middle of pandemic, talking about inputs, but how do you see now the continuing of the collaboration of all of you, and then strengthening this process from now on, and the institutionalization is a question that I have. Before, I would like to ask the collaboration so that we keep this group together. I think that's very important. We have seen in the last 2 years the organization of the process in the coordination. What I remember, we did about 8 or 9 amendments, and there's a project that was supposed to be 3 months, but in this thing will go much longer than 3 months. And the issue, this is very valid proposal, and I would like to speak with all the colleagues if they're interested to keep the strategy. I show that I want to put forward here my interest and keep with this group and the research. I remember the first meeting we had about 50 hospitals on the screen. It was so full, you could barely see everyone. And I think that yes, we can make this project keep going. I'm going to switch quickly because we still have a matter from yesterday afternoon, which is a question of APS. Our colleague is still here. We need to do this discussion on how APS organized. Professor Ricardo, thank you very much. Fernando, I would like to at least ask a question and see if you could. I would like to also congratulate the presentation of all the hospital. It's very rich, every information, and each one is singular. I would like to reinforce what we have been doing, which is at this time of work after these 2 years, we have a practical community and keep interacting with all of you in the governance committee. See if those who take care of data in the project. What's the most important now is to interact with the hospitals and generate report and data and research. We go through a step that is very pleasant for all of us with academic background that work in the publication along with it. We have a great challenge. Later on, we're going to have something coming out from CNPq, an editorial that we work with details. We're going to keep working with this community in hands-on as well. Thank you very much. I would like to say something, is to take advantage of the authorities present, and I think it's an adequate moment. A problem that was a little clear is artificial intelligence and the importance for this composition of this database. But our reality in Brazil, many of our hospitals don't even have clinical history that is technological. It's not even in technical standards. This would be fruit of competition, of free market. I think that it would be important that we have a law making it standardized to have the information that's the same for everyone and should be exported in an adequate manner with no problem in having to extract more. For example, temperature, heart rate, all these things that are already extracted normally, they could be like standardized by law so that all the electronic data and charts that come would make it easier so that the prontuary come out faster. So I think it's very important that we all agree here that the data need to be in real time, given in real time for that person who's right there. First line can transform that into an attitude that is immediate, of immediate action. So if we have these normative by law, so they can be done by law, so that they are, it's mandatory for a sanitary institution to do that. We could do that. We can complement with artificial intelligence, with all peculiarities, so that they don't have such a huge work to do. I can imagine how that was in order to present data that were just simple. Stuff that we could do simple, so we could all standardize all that. I think in the whole Latin America, utilize Fahrenheit or Celsius. See, all this there should be a law enforcing it so that the person is there ready to export the data in a very set form. Things that are routine, so that we can give real time the data of what's going on in a situation like this, so that the research, when they can understand the behavior of COVID, is important. So for us to face the new for the future, so we can face the unknown, and that's what we could finally maybe leave it behind for others. Good morning. Thank you for the presentation.
En la parte clínica.
In the clinical part, post-COVID, if you could go deeper, in the cognitive situation. Você tá ouvindo?
So we thought about how to maintain the follow-up on these patients, because after a while, it's important to have this follow-up to understand if they think, if we have the data collection, if we had an initiative about this. About the proposal to follow up after the primary health care or in basic healthcare units, we don't have anything in force right now. About the findings, the cognitive findings, specific neurologic findings, we couldn't filtrate this yet. And we have to separate, and we had to separate the data, and we had to study this in a best way compared to others. What we see as predominant in the base care units, the samples are very small, and there are some reports, they are very superficial about memory alterations, and some alterations are smaller, but we have a small sample, and most of them were about muscle disease and psychotherapy and physiotherapy. This was the most present in our primary healthcare unit.
I'm going to excuse now to comment according to on MINC in our infirmary. Like my colleague said, to filter into the platform, the filtering is still being refined. I can talk about it because it's been my study. The neurological questions were not the most prevalent. Still in the most COVID phase, we would see that was more frequent, the muscle area, but this was not much in relation to memory. People had difficulty in naming objects, more superficial abilities. Depending on what the patient complained, we would take it to a specific lab of neurology. It was not so much significant as others, though, but these patients were followed. They were followed throughout a year. But if they had no complaints throughout a year, we just let them go like in a normal hospital. But if the symptoms still persisted, then we would take them to the correct ward. That's what happened today. But it's the complaint of memory loss has been most significant ones. Those that we followed. Some people still had that issue after 1 year. In relation to the follow-up, the ambulatory still follow up with these patients today. I think that's all right. In the pediatrics, we did not do ambulatory, but the patients were followed in the pediatrician ward that they were normally received. We didn't have a special tool, but we just would listen to the complaints that they brought. So the data was a little harmed here, but we saw some difference from the adults. We had more motor and the respiratory complaints. The strategy that Conceição said is not to create an ambulatory post-COVID, but attend any patient that had issue with neurology or respiratory, and we would attend these patients whether they were post-COVID or not. In this group, we saw the post-graduation, the molecular issues. Some patients came in with neurological issues, a little more severe in itself. And another issue is that the neurological issues were present. I showed yesterday depression and anxiety were more frequent. The neurological was not so strong in post-COVID as these. The experience that we had post-COVID was very similar. Depression is one of the symptoms very common that were shown. I would like to now answer and put it together with the first question. The question that you raise, our answer are very set on, and the base that is formed, we're able to see a systemic view of all the behavior on national and international level, and with this we're able to generate indication on how what are the most common comorbidity post-COVID, so that the public policies can be made and projects can be done. So this database has generated all that information, so then later we can make decision on the public policy regarding this. So COVID is an example. So the database is important, so it's evaluated in very structured way so that decision can be made in assertive way. And that's, I think, was the most important idea that's coming from all this. So it's to show the results inside the institution and the public policies. I would like to make 2 comments and share with you 2 worries. And I'd like to discuss some patients because this question, the neuropsychiatric issue like memory loss and everything, I think it's very related with the working profile, what they did before, the patient did before. So this complaint, post-COVID, this lady that was complaining, she was a psychologist, so she was losing her memory, but then so the answer is take her to a psychologist, and that helped her. So when we think about future and public policy, looking at these data, I think it's a very important thing for us to do this relationship with a previous relationship and their work as well. So subjective complaints like psychic issue may be very well related to going back to their life before COVID. Another question is, what's the difference between in the hospitals that did their own ambulatory when they didn't have one? Or in other words, if you received patients post-COVID from other institutions, and then another question is, one of our cases was a diabetic after cut therapy and did a bronchial surgery or something. So for the excess of corticoid she was given, and that's a serious case. Could that be a problem to have mellitus diabetes and corticoid?
At first, we haven't identified any cases of diabetes post-COVID. We had patients that needed the use of corticoids, FO2 that were higher, which are risk factors. But we have received only our own patients because the number of consultations were very restricted. Today, these basic care units are open to other patients. So these COVID patients, they are diluted in the basic units. It's a little bit more difficult to find them in that evolution. But in the beginning, we haven't had this opening because we couldn't do that. So the 200 cases are our cases. It's just out of experience. Just adding this question about diabetes post-COVID is one of the items of the research. It's one of the questions. So we have to strengthen the base of the database to see if this is something that we have to take a closer look and take action, or if they're isolated cases. So this strengthens even more the database that was built in this project. Well, initially we had some patients from other hospitals, but this was due to internal references by the own doctors. They knew how this was working, and there were no basic units at the time that were receiving those patients. But there was a moment that there was a way between the patients that were hospitalized in the ICU and they had direct follow up to the basic care units and also some outpatients. So the first patients could be from out of the hospital and they were included in the study. About the medication, we don't have any findings about that. I remember one patient that developed hepatic problems and it was investigated, but I don't remember about the medication. Any other comments? Professor Tapi? Just to close the table, this is a deep discussion. So we have different scopes for the management of the hospital, the pediatrics and the workers' hospital. And I am a pediatrician, I'm sorry. And when we do that, we have to see a closer follow-up. And the use of corticoids, for example, is something that is quite old. I wouldn't say that this is something new, but maybe the methodology, the clinical models. But I remember that in the beginning of the pandemic, the homologation certification that we were doing at the moment of the behavior of children was the Kovacs syndrome. We were seeing some similarities and the clinical model for treatment. And well, this was developing and we had a specific planning about that had a great effect. And we don't have a more amplified application. And of course, this depended on the variant. And then it is a great challenge in the clinical research. We don't have an agenda for this kind of treatment. This is evident. So we're using the medicine, the intensive medicine, to follow up on that, and the pediatrics and the psychiatrics. But this is something that is quite exploratory. We're seeing what we have of positive, the technology, So we have different words, different worlds here, about treatments, about intensive care, and we have to do a lot of research, and we have to see what's happening in each center, and we have to share in this network. So this means that we are in a situation that is still very basic. So the research has to be something permanent. So if we don't compare the conditions, we won't have an efficient response. And I think that we are a little bit far from that. We have to do a permanent effort. We cannot unlearn, and we are still very far from that. We can still be more efficient to face the challenges. So this is just a comment. Thank you, Professor Tapi. I think one more comment, and then we're going to have a break. Yes, I have a comment about what we're seeing in Colombia and what I saw in the presentation for long COVID. It's the difficulty that the basic care unit doctors identify the COVID-19 symptoms and also the care, because some people have respiratory symptoms and they have problems, for example, cardiopathic problems or health problems or mental problems, and they want to have an integrated attention, integrated care, and they have to go through other doctors, and this is very important, because when we see the incidence that is being reported in Europe and the United States for long COVID, it is worth to concentrate the efforts in a care that provides research, not just research, but also a better follow-up on the patients. It is important. I agree. We should have the main coordinator of this should be basic care, so we could have this coordination. Our hospital really fragments the care of the patients throughout the many specialties, and I agree that we should have something more global so the patient could see this in a whole way. So we try to do that, and I agree that this is really important and this must be sought. Well, when trying to have something similar, this already existed in the rehabilitation hospital, the multidisciplinary consultations that I mentioned in the presentation. This was already an approach, especially for neurological sequel patients. So you have a doctor, a neurologist, a psychiatrist, a physiotherapist, and another doctors in the same decision. So this is still something very important to see the patient as a whole. We have to develop this in the basic care units, and this could be structured in a way, because this fragmentation is not good for the patient and it overloads the tertiary services. I am going to close the table now, but I confirm the opinion that the basic care is important. They have different arrangements according to each place, but we have to maintain a line of care focused on the patient's needs. So I think this is key. And we put the basic care as a centralizing point of all of this. Of course, the tools are needed, and potentially we're going to identify what are the main symptoms, what were the main conducts, what were the main difficulties to identify long COVID, and the cases that will aid the setting of a protocol. So thank you very much to everyone here at the table. Well, we conclude now, according to our chronogram, this roundtable, and we're going to have a break. 10 minutes for some water, some coffee, and please, we'll ask all of you to return so we can continue our activities in this morning. Thank you very much. Hello, everyone. Once again, good morning. Please, if you could please take your seats in the auditorium so we could continue with our activities in this morning. We ask all of you to return to the auditorium. We're going to start now. We're going to have a picture now. And we would like everyone in this auditorium, please. We would like everyone to be present at the moment. Let's wait so everyone can come in so we can have this picture taken. No. Online aqui, ó. Okay, very well. So I would like to invite the ladies and gentlemen that are here in this auditorium, ladies, to have a picture taken, please, can you come here to the front so we can take a picture? This is a strategic and historical moment. So everyone gather here so we can have the picture taken. Lady. Thank you. É terrível, né? Please come, everybody.
Thank you, everyone. Thank you so much. All right, ladies and gentlemen, while you take your seat, I'm going to talk about the layout for the next table. Table number 5. Um, the research of sharing the results of clinical characterization and management research of patients with COVID-19, contribution to the global clinical platform. To coordinate the activities of this table, ladies and gentlemen, we invite José Cesar Gato, Director of Teaching, Research and Healthcare, Depas Meki. Is that right? Okay. Depas, perfect. Welcome. Be very welcome. I'm also going to invite the panelists, the 4 of them, that's going to be in this round table today. Hospital workers, Hospital das Clínicas. Shirley Lopes Dias, please come to the table. Nurse and epidemiologist and coordinator of the epidemiologist department in São Paulo. And the next one, Francis Tomazini, please. The coordinator in the group of information technology. Very please welcome. Now the second institution, ladies and gentlemen, State Department of Health in Espírito Santo, Vila Velha, and State Hospital, Dr. Jaime Santos Neves, the nurse and controlling epidemiology surveillance. In the same institution, we'd like to invite Patricia Teixeira Gomes, please. Nutritionist, coordinator of Education Center, Research and Innovation, Dr. Jaime Santos Neves. Welcome, Patricia. We're going to go now the third institution, Hospital Getúlio Vargas from Piauí. From there, we have Osvaldo Mendes. Dr. Osvaldo Mendes, please. He is Doctor in Medical Science of the Federal University of Piauí and General Director of HGV. Please welcome Osvaldo Mendes. And we would like to invite from the same institution, Nirvania Carvalho. Please, Nirvania. Nirvania is doctorate in the nursing management of HGV. Now the fourth institution that's going to be represented on this table, Regional Hospital of Lower Amazonas, Valdemar Pena of Pará. We invite Mariana Martins Quiroga, please. Please, Mariana is an infectologist, postgraduate in epidemiology and hospital control, infections control. Now the table has been formed. Coordinators, ladies and gentlemen, you have the floor. Good morning, everyone. Thank you for coming back so promptly. Thank you for the picture. It's going to be very interesting so we can all have this moment registered. Thank you for the structure from Pajo has given us. Now we're going to have Shirley from USP to speak first. USP is in São Paulo. Let's share the screen. Good morning, all. First of all, I would like to thank the opportunity to participate in this project. Even though HC was less in everything, we can now contribute. It's a big honor to contribute with the institution. I'm going to show the preparation, how we mobilized in São Paulo city. Well, to talk about the history, HC was one of the first main reference in São Paulo, severe cases of São Paulo in São Paulo. And a little bit of history. In 1994, it's a hospital complex with more than 600 area and has several institute and have the INCOR, ICE, INREA, INRAD. It's infinite, numerous institutions, and some of the work that we do. Now we have 2,716 beds in HC. At the time, during COVID, it mobilized in our nucleus. Towards the end of December, we were following COVID, and the crisis committee was already there in January. So the crisis committee began to mobilize because at any moment it could affect the institution. In January, on the 29th of January, they were called upon several areas, CCA in our nucleus. And already in the beginning of March, we amplified the committee in order to discuss how we could resolve all the demand that could possibly occur in the municipality of São Paulo and the greater São Paulo as well, adding all the demand that we had. It's more than 15 million inhabitants in that region. And then in the questions of in a matter of 5 days, the whole central institution will be there in a picture. It was completely emptied, all the beds and all the institutes around, they all absorbed these patients so that it could be exclusive for COVID. In this, we were able to isolate and have 300 ICU units and 900 infirmary beds. There's the Central Institute where all the involved area, all the nucleus, HC and clinics, all the areas were isolated in the central institution. We had no communication, at least at first, with the other areas and units of the hospital. And this mobilization, that's how it worked. I remember like it was today. This was March 26th. Everybody was there already taking care of the first COVID cases in the municipality. And then a very big contribution from Francis in the parts of IT that represents that today, together with the clinical directors, began to structure forms, because since we had only one door to admit these patients, is that we could get as much information as possible. So we did this form with a few topics. This is the first page, just so you can understand. We would put where the patient was going to go, what he did, what he presented right when he was at the unit, what kind of symptoms he had. And that made it much easier, especially for CRF, because we were able to compile all the data. And we called it a COVID form. These data were structured inside our electronic apparatus. And this initial sample for the network was 6,711 chart analyzed. We were able to analyze all those. Unfortunately, it was a big problem. The Heart Institute and CESP have their own chart. Each one work with TASI and another work with S3. So because of this difficulty, we were not able to put on the network at the time, who knows in the future, maybe more 6,000 patients from that time as well. How was happening? The patient would come in, And since all the nucleus were in the COVID unit, we would validate everything that came in from these charts. And for practically every 2 days, we would compile these data and we would put daily reports raising together with our residents from March to September. All the residences or the residency were canceled because we didn't need that, but we needed help. So they all helping the clinic and to establish all the important information and necessary information that what really contributed to the COVID group in the institution that we had. Now we have a very structured area, and with the platform, we're able to widen it because the volume of information that we gathered was huge. So it really enriched our data. And this data dictionary, in fact, I grabbed a picture of how this job was done. What we did, we compiled each area in order to decode. Francis knows this technical part a little better than I. In order to extract this data, it was a very tough project work. But in order to compile this information at the end of October, right, Francis? So we had very little time to raise all this information, but it worked. It all worked out. I can say that with all this, it worked. This is what I can say. So here, our work was done. This is how we put the CRF. I put just some of the data. We put a specific lingo for this, and we put a column, different columns, so that we could put where to get the information in each form. So myself, together with the researchers, we looked at each box, and we filled out which one had to go to ICU. So we did this manually for weeks at first. It took weeks to do that, but when the whole program was ready, the basis was basically mistakes were very minimum. We kept mistakes to a minimum because we had every information there. We were able to compile everything we had. And some of our results here, like I said, it's been 6,911 cases that we were able to compile in this stage. The HC has more than 12,000 positives, and today putting our data all together with employees is more than 9,000 employees updating our database. So we have 3 datas, very rich datas. One of our great difficulty I didn't put here was that the cases that would arrive at the unit were very severe. So from the moment of the start of the symptom to arrive at the HC was 10 days. So the patients were sometimes in the ventilator with lots of lesions. So that's why the amount of patients in ICU was very high. One of the things that we were able to contribute was the data of how many women were pregnant. We were able to get about 400 women pregnant, so that was okay. We had an exclusive area just for them. We were able to do that. And then a little bit of the profile. Medium age of these patients were about 57%. The 57 years old. The medium is 59. Medium time that they were inpatient was 11 days. But what I analyzed, that when they arrived, about 65% of all these cases went to ICU. So because of the complexity, and from these cases, great part, they went out, thank God, the patients recovered. And the great data that called attention is that the males that arrived in our unit, they were with most severe. So therefore, the death in this group was much higher. The median time of hospitalization shows here in the Institute of Children, for example, we have a small number of children. Here's the proportion of the cases. We can see the symptoms that they showed. What called my attention was that a huge part showed that they couldn't breathe. It was very complex what they had. This is a temporal distribution. It's a very big. The hospital was closed for 6 weeks during COVID, so we have a big problem. If we look at other places in the country, compare that to the other places, unfortunately, we try to keep the death low. In the cases, nowadays we only have 30 cases of COVID in all the complex. Like what I said, the death, what calls attention, especially in the male sex, how they arrived very severe. They were the ones who were most affected. And then one of the consideration was historical for us. I see that all the team that could watch can notice what we went through over there. Is exclusive entrance, what we do, all the screening, triage, all the employees as well as the patients. We had the very difficult problem because we had the peak during the pandemic that we had more than 700 employees were away. We had to have a huge infrastructure, therapists, engineering. We have a picture of all the generators and the support of oxygen that we had to put for the demand. And recently, all this arsenal had been deactivated, especially because now the demand is much lower. And what did we learn? I think it's important when we do our consideration in the institution is that we need to standardize our system. We have still a very large difficulty. I think Francis was also her difficulty, and the team that worked with this, that the data came from collegation that worked on it, but we weren't able to notice the institution, the data. The CESP or the Heart Institute or Cancer Institute, these are data that are compiled by the vigilance team, but an IT team. They do the report from the vigilance nucleus and look at the data. They're able to push and extract the data and feed the bases. Not necessarily they talk about it. It's usually fragmented, so there's a need for the institution to work in standardizing this so that we can produce more knowledge, work better with the forms and structure them, open door and train these employees in order to fulfill and solve these problems. Like when we would look for these forms in his structure, it wasn't filled in. So, for example, a patient would come in with more than 8 months that they were in the hospital. So how could we find the form that he had? And in order to find this database, to work with the qualification of all of them in reality.
And the surveillance mechanisms. Metagenome, improve the entry doors so we could detect the possible emergencies in public health. I think it's one of our greatest learnings of everything that we have gone through and the pandemic for the pandemic in the institution. I think the greatest challenge in the construction of this dictionary and this database is that we had initially. In the beginning, we had a small base, and we had this for small cases for our demands. And also, we had an intelligence team for that had to develop the automation that was happening during the operation. When the patient checked in the hospital, we understood that this patient needed the ICU or the ambulatory. We had to have the resources for this patient that were coming to our hospital, and we had to have this in an organized way because we didn't have the control over the pandemic. So the automation that we built and the intelligence, taking a look at this patient's journey, this was a facilitator to have the initial basis. And also taking into consideration that each system was different, we need to standardize the rules, and we need to see about the operation what was the greatest incentive for the journey of the patient. So to codify these reports was easier, but we didn't have the artificial intelligence. You brought this from other hospitals, from other experiences. We didn't have this at our hospital, so we had to work in a different way. We had to restructure this so we could bring this dictionary and do it in a better way. About obstetricians specifically, our hospital treats high risk patients to high risk pregnant women. So this was moved to the university hospital, and only the patients that need the lacrosse for this regulation of emergencies. So thinking about the initial report, which was the great entry door, because the emergency room would have all the registration from this patient, this was the greatest guideline for us. And then from there, we went seeking if this patient was pregnant or not, and how could we bring this patient to the hospital. Also, we had to have the vaccination. We had to contact the initial hospital in the journey, and also we had to take a look at these collaborators, and we also had to do the accountability of everything that was associated to COVID and the Institute COVID. So this experience, the greatest challenge is that there's not a good journey if there's no good information, and the professionals, they have to understand what they're registering, because eventually the research for the research it's important to have the registration, the right registration, and that it makes sense, so this information can be cross-examined in all the processes, and that we can have opportunities like we have today to build the knowledge from what we have in the database. Well, thank you, França. Now we are going to leave the questions for the end, and we're going to go to Juliana and then Maria Patricia. If we can change the presentation, please. Good morning, everyone. On behalf of the Health Secretariat of the State of Espírito Santo, I would like to thank Parro and Ru, especially Rosane, for all the support given to us. And I would also like to thank our institutions, which the Hospital of Vila Velha and Dr. Chaves, and all the teams for their efforts during the pandemic. Well, in relation to the research, we chose to coordinate the research through the Research Innovation Institute, which is the School for Innovation in the state. And As a research field, the two hospitals were chosen, the State Hospital of Vila Velha and also the State Hospital Dr. Jaime Santos Neves, that have acted in the most serious moments during the pandemic. Thank you. So, the State Hospital of Vila Velha is a public hospital for adults. It is a state hospital located in the municipality of Vila Velha in the region of the state of Espírito Santo. Before the pandemic, it was a hospital for low and medium complexity. We didn't have any ICU unit. We had about 90 beds, and it was a medical clinic doctor with 5 surgical rooms, and we had orthopedic and hand surgeries. We were recognized in the state to have a 0 line for hand surgeries, elective surgeries. The access was exclusively through the regulation center. We don't have an emergency room. So all the patients, they have to go under a consultation, an emergency consultation, or any other emergency room from another hospital, and they have to be referenced to us. So in the case of the surgical block, it is regulated for our institution. Besides that, nowadays, after the pandemic, we have 21 ICUs. We maintain the medical clinic, and our profile surgery has changed. We now do ear, nose, and throat surgeries. And this was a change made by the state for the hospitals after the pandemic to fulfill the demands of the users. Besides that, especially for 2022, we became, during the peak of the pandemic, especially in July, May, August, we became a reference, 100% reference for SARS. Different from other hospitals in the state. It was a need because all the other specialties, all the other SUS consultations were kept, and we concentrated the SARS care in this hospital, including suspicion and diagnostic of COVID, tuberculosis, HIV, among others. During the whole period from March 2020 until August 2022, after this last wave, we had 835 hospitalizations in the hospital for all specialties. Out of these hospitalizations, 1,588 were due to SARS, and 839 were due to COVID-19, confirmed through a lab exam. Besides that, we also have the use of oxygen therapy in any modality. So the data presented here is for use of oxygen and for COVID-19 patients. We observed that the age rate of largest predominance was between 46 and 65 years old, and male patients were predominant. I think this happened in all institutions, right? Also, something that called our attention was about the comorbidities. In this graph, we are showing the hospitalizations that happened through the epidemiological weeks. We can see some peaks in 2020 specifically, Between June 28th and July, we had 27 hospitalizations. In 2021, which was our most expressive rate, there were 88 hospitalizations, and for a hospital that didn't have any ICU beds, we started having 39 ICU beds. So as the other hospitals, we transition those beds according to the demand, according to COVID panel and the epidemiological reports from the secretary. And in 2022, we highlight 65 hospitalizations between the week 27, 28 in June and July. And now we see a particularity because we were 100% COVID during this time. So that is why we have such an expressive result. About the number of deaths, the week where we had the most number of deaths was the weeks 13 and 14 in 2021. Something that we saw about that was the relation between deaths and comorbidities. They happened among patients with comorbidities, and now we can realize that patients that had chronic disease and they were older, they had a higher risk of hospitalization and death. According to our average days of hospitalization, we observed that male patients had a higher predominance as the other hospitals had. And we dare say that many times it's because we have studies that prove that male patients take a longer time to look for doctors and care. Also, something that we have observed is regarding our re-hospitalizations. It was a small data, and it can be influenced by our access to hospitalization. Sometimes the patient, when we have closed doors, the patient that was discharged from our hospital, he doesn't necessarily come back to our hospital. So many times he was in the emergency room, and because there were no vacancies in our institution, he goes to where there are available vacancies. About the results of the hospitalized patients, our death rate is very low compared to other hospitals. And if we compare to our global rate for other disease and for other hospitalizations that are not COVID, it is of 8.3%. So generally, our death rate is low. During COVID, we presented a death rate of 19%. For us, this was very significant because it doubled. Also, something that called our attention was about the transfer of patients. As a good amount of patients that were submitted through because of COVID, they had complications due to COVID or other disease. We have a general hospital, and some specialties were concentrated in other hospitals from the state, including the Jaime Hospital. So we needed an intervention from neurology or from thoracic surgery. So we had to transfer that patient to another hospital. something else that could have influenced this was the return of the patient to the origin institutions. Maybe a longer stay hospital or another small hospital. And when the management of that clinic was solved, the patient would return to that previous hospital. About the hospital in Vila Velha, these are the data that we can publish and we can disseminate, and then we can talk about the challenges. So let's talk more about this. Another hospital that participated in the project was Dr. Jaime Santos Neves. It is the largest public hospital of the state of Espírito Santo. It was opened in 2013, and it is administered by the AEBS. And the hospital, it was an open door hospital, and it had a high surgical profile. We have 415 beds. It's a large hospital of high complexity. We are reference, and we kept a high risk complexity level, and we are reference for all the patients in the state of Espírito Santo. During the pandemic, the hospital became the second largest hospital in number of beds for COVID-19. Before, the profile was highly surgical, and then we had to close the doors of our emergency rooms, and we were reference for regulation. And our whole structure for emergency rooms became ICUs. And we had 150 beds that were turned into ICU beds. And most of our beds became the COVID ICU beds because of the complexity of cases and the number of cases. So during the time of research, we had the honor to be able to participate and collaborate with this research at the very last minute. So, due to the large database the hospital has, we had the migration of data, and also we could present the data from the most serious patients. So during the period of the data analysis for the research that was from April 2020 to June 2022, we could collect more than 13,000 hospitalizations. Out of these, 19,000, sorry, out of these 13,000 were due to SARS, and we had the other data that 5,000 hospitalizations were due to COVID-19 cases that were confirmed through lab results, and also the use of oxygen in any modality that indicates this high-risk patient with serious disease. So in this, we had more than 5,000 patients, and then we can see that the age rate was presented was about from 46 to 65 years old, male patients. And we can see that 98% of the cases that were that were serious, they had some type of comorbidity. And then we had the peaks of hospitalizations by week. The most critical weeks had 101 hospitalizations. In 2021, we reached 132 hospitalizations by week. And we can see the highest number of comorbidities in this. And we can notice that the large number of deaths happened in 2021, where we had 85 deaths in 1 week.
The medium stay time of these patients, as we mentioned, the hospital Jaime is a reference for high risk, and it still is. We have in the hospital intensive therapy of neonatal. So that's why we're able to notice that there was newborns that were positive COVID. And when we went to evaluate the medium time of stay, and those who stayed longer, hospitalized, we should not forget to mention there was a high risk gestation. So there has a higher medium of hospitalization, but in general, the hospitalization was in about 14 days. When we talk about readmitting at the hospital, which is another variable we were able to observe, we had about 13% admission. Like Juliana mentioned, we need to be careful when we observe these data because the hospital return we're going back to be open door like before the pandemic, but we have to pay attention. Sometimes we have orthopedic surgery of high risk. As far as outpatient, we also have some burns, low grade burns. So when we bring these numbers, about 13%, we do not guarantee that was because of a reinfection or some other consequence of post-COVID. When it comes to the closing, we can observe that death goes above other endings, and this to justify the gravity of these patients that came and be hospitalized in Jaime. In other hospitals in other states would receive patients from COVID, but Jaime ended up getting the patients that were had COVID but in more serious way. Now it cut down to 5,000 inpatient. We are not trying to refine the data. We have a total about 7,000, counting with the employees, 10,000 total of them. We have a 45% mortality rate. On the other hand, we have an improvement of 43%. We have a closing of transference that reasonably transference. Why? Because this hospital became from high and severe chronic phase, and more acute of COVID had gone, but it demanded demanded other care. It would go to a smaller hospital. Those who participated in the research, these were smaller data, but that's when the patient left on his own, or maybe the doctor released him. Looking at this scenario, we are able to observe that the Secretary of State of Espírito Santo is expanding the beds, and that demanded a huge change in the internal process of Hospital Jaime, which used to be open door, very active surgery center, internal process. Before you couldn't stop to think about things. It's like the story, we cannot change our tire while the car is running. So this is all what happened. We couldn't do that. It was a huge impact. Jaime Hospital had a sector that was destined to helping those who are hospitalized, the residents, also ready for clinical researches. And nowadays we have more and more a sector that's more structured. We're able to see that the research is very important. We used to have that certainty before. We were able to show the whole constitution and also to the public and the importance of that on a daily basis. We still have that uh, program, the scientific capability. We show the difficulty of an adequate register a research like this. It's important for someone who's on the other end to understand what is a research, especially those who never had an opportunity uh, and to be charged to understand that, to the need and why to do a correct registry of information. With this, I'd like to strengthen the different teams more than ever. We were able to collaborate and see the importance of the therapeutes, ENT doctors, and the treatment and the rehabilitation of these patients. One more time, we thank you very much for the opportunity to be here and participating with you, and we put ourselves at your available for you. Thank you very much, Juliana. Patricia, now I would like to invite Osvaldo and Ivania to talk about Piauí. Thank you so much. 20 minutes, 10 for each. Good morning. I'd like to thank the opportunity for the Hospital Getúlio Vargas, allow Hospital Getúlio Vargas to participate in this research. We are a hospital of reference in the state of Piauí. It's a state that has about 3 million inhabitants. It's a poor state from the northeast of Brazil, where during the pandemic, HGV made a huge difference. Why? Because we in the hospital. We at the hospital, we did not stop answering all the other demands of patients with COVID. This was the biggest challenge because we are referenced in orthopedic, serious surgeries, brain aneurysm, ophthalmology. It's the largest hospital in the state, and we couldn't stop attending to those other patients. So what happened was a new hospital emerged inside the other one. We got the hospital with patients with COVID inside the other one. So it was a highly complex hospital with extreme research and extending. We have medical residencies and professionals. We have 369 beds, in which during both pandemic peaks, we enlarged our bed of intensive therapy, adapting some outpatient area. We have new beds, intensive therapy, and 2170 beds. In 1 week, we had about 90 beds that were structured. Our hospital is 81 years old, and during the pandemic, we had to. Well, the state puts the employees over 70 years old. They had to be put away from the hospital. We had to hire about 700 people. Most of the time, employees who had no experience, so we had to train them and make them capable to work with this. A lot of them had very little experience. They didn't know how to use the system as well. So with this project, we were able to see how much we matured in using the system. Our patients, in the majority of it, I say about 90%, were intensive care coming from the countryside. They would come from intensive therapy. Who were they? They were the patients who were positive in the hospital, which thankfully were very little, and the patients who left ICU but still needed bed in the inpatient or outpatient room. But these were intensive moments. This was a difficult process. About every day we had new employees, incapable, they were not trained well in the protocol, like many of us talked about IT as well. And so we tried not to let this happen between hospitals, because remember there were two hospitals in one. Most of them, they were not adapted to it. You have the incoming of patients, incoming of employees, so we had to re-adequate all the services in relation to the lab, image, nutrition, in order to have different flows inside of it, inside institution. So the first step of the research in 2020, we fed the data with 767 inpatient and 21 about 805 patients, and total of 1,572 patients. Like I said, a lot of them, we had a lot of we had to pay attention to especially the most severe cases and those with problems with breathing. Those coming from the countryside, when they came in, they had already about 10 days of symptoms. And in this the new questioning of the research was relation to how they were before they were hospitalized, because they were coming from other hospitals that did not have a structure of receiving a patient in critical situation, and they would come here, they come to our hospital, really need to be in the ventilator right away. So that was our reality. As I said, we had unprepared employees, an unprepared team, and we grew a lot as an institution with this and how to help COVID patients. We have a system called SOMV, which is not from the hospital. It's a system that is a tertiary system. We had a hard time getting these data, but working hard and with the proposal and the dimension of the project, we were able to have the external help to get these data from the system. We had so much difficulty because we had a mixed chart already, when sometimes it would be printed, others would just be in the system. So what really helped us was the form from SINA that we had inside the system. We were able to retrieve some data, and with information from the admittance of the patient, and that helped us because with time we were being sensible with all the information that needed to be given from the patients from other hospitals. And the data we were not able to extract, I think those in IT will understand a little better. That little box, information box, we revisited the charts. We collected a group of nurses, and the data that we couldn't retrieve, we went after those, looking for whichever way it was, maybe unstructured, but whatever we needed at the moment was to help as much as we could without the information we had, especially because the profile that we had were patients with very severe COVID, very severe situation. August 2020, we received about 443 cases of COVID. In March to June, about 2021, 697 cases. So an important thing I want to say again, that we never stopped receiving other patients. We had to put together a surgical center from patients with COVID, and our surgery rooms still with non-COVID patients. We did not have HGV. So we did the most to give this help. We were able to look at the population with severe cases, with 59% of them with comorbidity that we talked so much about, heart disease, hypertension, diabetes, which was the predominant in these patients. And the most part, they were with these comorbidities. Our situation with age, we observe that gender, mostly male, where the age was usually with the highest patients were 43 to 65 years old inside our state. And I brought here other studies that will corroborate with these statistics. And the product of the book that was launched today, they were not different from other research that we saw. I could see in Espírito Santo they research a lot in relation to COVID. I've seen it in my researches. The medium of stay was about 15 days. Also, with the age of 46 to 65 years old, as we receive most of our patients that are severe, the mortality rate is about 50% because most of them, as I say, did not have a previous help. As I said, they would come already in an advanced situation with catheter, high, very strong flux of. They needed oxygen. This is the area, the COVID area I told you about. Our challenges were really to structure everything electronically, and I say today that this project had great and positive impact in our institution in relation to the leadership in order to visualize everything in our database. All them talk to our employees about the importance of that. And institution, all the data of this institution sometimes were not available, which is a small town hospital, for example. There was the registry of laboratory exam and images. That was a challenge because sometimes we were not able to visualize these results in the system, especially because we have some exam in the lab that are third party made, and the inexistence of some data in the data bank because of lack of information in the hospital, information technology in the hospital. Now, to contextualize everything in the pandemic, all these pictures that were taken, it were from our institution during COVID, and was to maintain all the help from the patients that are not COVID patients, avoid to disseminate the virus. In our institution, we had a room for crisis where we would gather and talk about monitors, anything we needed, which employee that had COVID, who was away, in supplies, and every time the peaks would come back up, we would gather and talk, promote mental health for our employees, make our team capable, help their family, patient and their family as well. We had the experience of a video conference with the family so that they could speak with that patient that one day, their family member. And something I wanted to highlight was in relation to during the pandemic, we would evaluate, Anvisa was also evaluating the patient. And at this time, 100% conformity with the patient, which is our priority. We have data in the question of making everything standardized. We didn't bring too much data.
But I believe that this publishing of our experience will help other institutions that went through the same situation. So the lessons learned were the importance of permanent education of the health professionals, focus on the effective communication, the base of clinical practice and protocols, because many times the data was not filled, and this has impacted us in the search for this data. The participation of the management in crisis moment, the evaluation of indicators, so we could know all the patients that there were in that day. And we have our monthly report. It was on hold for a while because we didn't have COVID patients, but we showed the institution sex, gender, age, all the profile of the patient, and all the registration made by the health professionals. These are some references. So on behalf of Hospital Getúlio Vargas and on behalf of the state of Piauí, we thank you for this opportunity. Good morning, everyone. I would like to thank for this opportunity to be here learning so much in this rich seminar that makes us leave here better than when we got here, and to have so many interesting ideas. Many times I see, in spite of the many regional differences that we have in Brazil, it seems to me that when I was looking at the presentations from the state of Paraná, Rio Preto, from São Paulo, it seems that you were talking about my hospital. So the problems are very similar. So I thought it was very interesting to create a standardization of the medical records, so these situations are easier. I think that we had many deaths, and we are very sorry. And we had a mortality of 50%, as most of the hospitals here and as most of the high complexity hospitals that have high complexity surgeries of a lot of specialties, neurosurgeries, surgeries, we have to continue doing that and also serve this demand, which is more complex. So as you can see, we are larger than the United Kingdom. It's almost the size as Germany, the same size as Germany. So we had this problem with regulation of patients. Many times the patients would live more than 1,000 kilometers away from the capital. We had two high complexity hospitals, and Getúlio Vargas is the main one. And these patients would take a long time to get here. They would get here in a very difficult situation to be admitted to the hospital. And we can see here that many problems that you had, we also had about the collection of data, and we've had many learnings. The telemedicine was a very humanizing thing in the hospital, because many times the patient was intubated, but the family would ask the psychologist to work on that. Many areas, many professions, they have really developed in this period from the human point of view, because they have committed to the same purpose. And the hospital was very united, and the psychologist would explain the situation of the patient, but the family wanted to see the patient, so this would bring comfort to the family. And with this with the size of the state is very big, we started the telemedicine consultations, and this was something that we gained with COVID. something that we learned a lot from the hospital, and it's a reason to reflect upon this. We have to think about the construction of the hospitals. We don't know if the pandemic is over. Many pandemics can come. We talk about COVID, but we can have others. And something that we have learned is to transform something that is almost intangible to us, is to have COVID beds and ICU beds. We learn how to do it in a morning, create many beds in one morning, thanks to the help of the government with breeders and monitors. We transformed many ambulatory units into ICU beds. So this was a great development for us. And there were many learnings. These were the main ones. I would like to thank you once again. Thank you for this opportunity. Thank you. Now we'll go to Mariana. Please, can you put her presentation on the screen? Good morning, everyone. So I can't start this presentation without thanking the OPAS, the PAHOS, I'm sorry, team, and also for the patient. I think we were the last hospital to be in this study, so we needed a lot of patience with the elaboration of all the data, and also the team from the hospital in Baixo Amazonas, because even though we were in a transition state because we were changing the management, and we needed the support from the team, from the legal part, and we need support, and everybody worked so we could be here and bring you the data. Well, to do some characterization of the region, the state of Pará is in the north region of Brazil, and it's an immense region. The region of the lower Amazon is in the northwest of the state of Pará. The municipality of Santarém is next to the Amazonas and Tapajós River, and it's a very strategic region because it's between two big cities, Belém and Manaus, and there is a touristic and business flow that is quite large during the whole year. And the hospital is also located in the region that is in the limit of Tapajós. And in May 2021, it was the only hospital in the whole region, in that whole region. So we serve 21 municipalities of the region, and also we serve the southwest part. So the last census said that Santarém is the second largest municipality in the state after Belém. We had 461 SUS beds and just 20 ICU beds for adults. And part of this population, it lives in the rural area. And they have no roads, no access, and most of the access is done by rivers. And most of the time, the means of transportation are boats and we have 34 basic care units. We had also a team for family doctors, family medicine, and we had more than 40,000 cases for COVID-19 and more than 1,000 deaths in this period. And this is with the period that we included in the study. The hospital, the regional hospital of Lower Amazon, was opened in 2007. It is a hospital of medium and high complexity, managed by a social organization that up to November 30 of 2022 was the health secretariat, was a health organization, but we are in a transition moment, and this is a very turbulent moment. And we are characterized as ONA 3. We have 153 beds, 20 adult ICU beds, 19 neonatal beds, 10 pediatrics beds, 13 clinical beds, 49 surgical beds. Up to in last 4 years, we're doing also some transplants. 19 pediatrics bed, 21 beds for cancer treatment, and 2 for obstetrics of high risk. This whole region of the Lower Amazon and Tapajós, they had pediatrics and neonatal beds. So we have also 5 rooms for radiotherapy, and these were also suspended during the pandemic. We have therapies also, and it's also a school hospital. We have a residence for multi-professionals that happen in this hospital. During the pandemic, the hospital was a reference for moderated and serious cases of COVID-19. In 2020 and part of 2021, it was the last reference hospital for the whole region, not just for Lower Amazon, but Tapajós region. From 2021, there was another regional hospital that helped with the flow of patients and the transfer of patients. Santarém has had a campaign hospital during the period. We also had basic unit care facilities. We had some hospitalization of intubated patients. And our patients, they are referenced to us by other hospitals in the region. And we got to 96 COVID beds during the pandemic. There was the creation of hospital beds from day to night. And we closed the door for transfers from other specialties to whole floors that were destined to COVID-19. And our emergency room was also transformed and used for patients that had COVID-19, especially for our internal demand. Although we are a reference hospital and we are closed door hospital, we have patients that are going under treatment for cancer and other disease. So part of our demand came from that for patients that seek for treatment. So the worst time was the second peak. We got to 70 ICU beds for adults, 30 for pediatrics. And the hospital underwent many renovations. the open room was closed. We changed a lot of structures, and also the ambulatory was changed. But the main challenge was the human resource part in a region that where we have low human resources, and part of our team come from other municipalities.
And these were called to work in the outpatient and the nursery in the hospital. They were all called and hired new professionals in different areas called to help with COVID. We had a place for helicopters to park near the hospital, because that was a difficulty we had at first, to transfer these patients and through ground. So a helicopter from the state was available for these dense regions of the inside of the state. The first 6 months of the pandemic, we only had PCR in Belém. So sometimes we had the diagnosis, it would take 7 to 10 days, but then when the cases were higher, that took even longer. So that was a great win when we had a partnership with Pará. We had a machine from other state, and the kits were donated by the state. Labimol is still works today in order to centralize this whole region of Pará for diagnosis. So it made that, and it still works today. It does not work anymore just inside the hospital. It has its own place, and it was a great victory for the region. Well, I have the committee, the COVID committee here, in different specific sectors of the hospital. In the beginning, we would have meetings almost daily, but then a little bit later, it started to be less and less. We also had change in protocols. We went through a period of important sometimes we had to rationalize the drugs in the ICU, and that's how we managed in order to have this make it work. As far as the results are concerned, with all this issue that we had with COVID, we did not have a database except for the strictly necessary indicators or specific ones. And with this, the participation in this work was a huge gain in this area, in order to have all these data to stop and see what had happened. Since all of us were so involved in helping that we didn't have time to organize and analyze what really happened. But also as an opportunity to improve and see what we needed to. We had only 60% of the electronic charts installed in the hospital. We had the charts, but the 60% were in the ICU. So the rest of the hospital, only during the pandemic, we had to work on it. So the data, in order to collect these data, there was a kind of difficult. These were faults that we had. These that were missing in the chart, the electronic chart. In March 2020 and 31 May 22, it was a period where the hospital analyzed these data. We had about, the back now. 1,505 admitted because of COVID, following the curves that our colleagues showed here. And the world epidemiology and the most important wave was January of 21. That's when the case of hospitalization increased, and they follow the peaks of hospitalization. And the predominance of the hospitalization were male, and then 1.5% were health workers, and the female patients were mostly the pregnant women, the population that are a little less protected. And this is the data that we had to analyze from these pregnant women. 3 with 2 doses, 1 with 1 dose. Vital signs in admission, 57% IRM, 39% with oxygen low, 95%, heart beat, 36%, 10% had fever. And the symptoms that they mentioned, 57% had arthralgia, 53% dry cough, 53% headache, 46% loss of taste, and 32% asthenia. In the pregnant women, a frequent problem in helping them in Santarém is the rest of, we have this issue is to help pregnant women. I work in basic assistance, and we try to educate, we try to do promotion and try to improve this aversion to the vaccine, but it's difficult. Maybe it's a little cultural. It's extremely difficult with this pregnant population, the pregnant population, as well as with senior citizens in this area of the country. We do everything we can be doing inside the unit, but that's a separate talk. Lab alteration, the most frequently found was the D-middle, 72%, DHL, 68%, leukogram, 46%, 36% had some kind of hepatic enzyme, and 32% was anemic with less 12. Complication with these patients, they were low weight, prematurity, that was the most common complication. The baby's death was also, it happened. Some from the 28 would occur. The mother was mostly shock and renal insufficiency. And our hospitalized patients, 97% had done these diagnostic tests, PCR and TRAG, 98% positive. The median age that were hospitalized were 58 years old, mostly male. Patients in the 61 through 80. In the female gender, what we observe that they're mostly 22 to 40 years old, or 13 to 21. So women, they were a little bit younger than men. And I would like to bring this other data that I could probably not show in this, unfortunately show here, is that I miss not seeing the natives. In our region, we have many natives, different ones. For example, Kayapós, we have them in our region. We did have some of those, but with this ethnicity, but not in the Quilombolas. We put it as black, and they highlighted I missed having this differentiation here as far as ethnicity goes. Admission, more data on the admission. 55% of our patients, they come from a central group. 45% come with our open door in our hospital, like I mentioned before, and 55 from other hospitals. They came with heart problems, heart complaints, and these are the criteria from the protocols. Considering these criteria, 76% of our patients were in the ICU, admitted in the ICU. 83% received intensive therapy. And if we go back to the other slide, remember these characteristics? They were, so 83% of these were admitted straight to the ICU because of the gravity of how they would arrive at the hospital. And they would have a tomography of the thorax, of the chest, and have issue with lungs. Their lungs were compromised. The medication that was mostly given was antibiotics, and 82% of them had given by the doctor, prescribed by the doctor. 10% got health insurance. We had 53% death, extremely high the death rate. The way the patient would arrive, and the kidney issues and the heart issues were the most common comorbidity from these patients when they would arrive. Immune deficiency as well. And now I wanted to show the result of the vaccines and analyze the vaccination, both from those who were hospitalized. 65% had 0 doses when they were admitted, and 70% of those who died also didn't have any. Those deaths, only 20% had 1 dosage, 9% had 2, and less than 1% had just the first booster and second dose. With this is what the reflection I made. We could improve this. The assistance I can give. I'm here, and I end my presentation. Thank you all. We are available for any questions at the moment. I think no one has any questions, so IBSERA is very big, as in 24 of all the federations, so we saw all this happen in our hospitals the same way. So that helps. It was the same for everyone. The difficulty in hiring everyone, it was a huge challenge. We hired more than 7,000 people because we opened jobs that from nothing, and we had a high turnover. So in the hospital, in the ICU, we put several beds, everything that never existed before. In the small areas in Paraíba, we put 30 beds in the ICU. So the same challenge for everyone was to retain talent is really hard. People did not stay. The turnover was very big. After 4 or 5 months, people themselves did not want to continue. So it was really hard already, because you didn't have anyone like that. And those who specialized went to the private sector, and then you couldn't keep going. So it's really important to prepare these people and educate them so they can stay and learn more. And we had help from others really, really well. And it's not the same for the public to use our hospitals and if they were to use the private ones. The difficulty in keeping charts, we have 41 hospitals with 41 different systems. Even though now they're using GHU, at the time most of them did not use. Some use in a fragmented way, and now 4 years later, the administration were now finally able to implement. But anyways, they each have their own database. And for example, we get 4,500 new medical students every day, and it's hard to train them to have the same glossary and everything's something that USP suffers. It's hard for you. You receive many residents every year, so it's a challenge. And the structure, like in Espírito Santo, is a area, and it's very big in Vitória, so it's in the middle of the way of both sides of the state. So Santarém, I went to consult this 12 times larger municipality. Santarém is 12 times larger than São Paulo. So very few people had an idea of that. So we went to look at that. We have an idea of the dimensions of the state and dimension of Brazil and how it impacts. Espírito Santo has 46,000 square kilometers. Going back to Pará, the Ilha of Marajó has 42 square kilometers. So a place in this country, and all the suffering that everyone went through, not just the people here at the table, but everyone who's following us. It's a huge challenge to bring knowledge and then bring this understanding. All this exchange of information may help us in the future to create systems of information, because right now we have data information, but it's useless. It's just a agglomerate of things in there. Inside the university hospitals, we have the interest in research. This might become publication. Those of you used to make decisions on daily basis, but from that to manage health is a big challenge for all this. Like to take data from the paper and go make it to the data hub, and how to make that a decision, be it every day or in the hospital. It's simple.
So for the state, for the size of this municipality that is 12 times bigger than the most important city in Brazil, it is very difficult from bench to bedside. So how can we do this in the real world? How can we turn this into a conduct? So it is important to get this information together and to bring this to the managers so that they can understand. It's not worth bringing a lot of data because they're not used to that. Today, the president of CONAS and the secretary of Espírito Santo, he knows that he likes data, but this is a characteristic from him. It's not the average behavior. So to do these translations, these extractions, I think that this is PAHO is one of the biggest responsibles for that in the Americas, and to be able to take this experience to who. Thank you very much. Now I will give the floor to the MC. We would like to thank everybody who integrated this panel, and we have concluded the activities for this first activity before lunch. We have our break for lunch now. So now it's 1 p.m. and we'll be back at 2, okay? Lunch is served, so feel free to participate at lunch, and at 2 we'll come back to the activities. We'll resume the activities. Thank you very much.
y
não se arrepender. E eu queria, assim, justamente isso que eu queria.
Hello, everyone. Good afternoon. Welcome. We ask you kindly to take your seats, please, so that we can give sequence to our activities. And those who are following us remotely, we are going to now, ladies and gentlemen, from now on, talk about get together for the roundtable number 6 in our seminar, and the roundtable that closed the seminar as well. Our central theme for this roundtable is sharing the results for clinical care restoration and management of the patients with clinic issues with COVID. We have we've been honored to talk to some institution and to coordinate the activities of this table. We have, we're going to call Dr. Ricardo Kuchenbecker. He's doctor and epidemiologist and risk management from Porto Alegre. He's a professor of medicine in the Federal University of Rio Grande do Sul. Please, professor, take your seat at our table, please. He will be then the coordinator of this last table in our seminar. I would like to invite as well to take a seat at our table the representative of Integral Medicine, Fernando Ferreira, of Secretary of State, Leila Katz. Leila Katz, perfect, yes. Dr. Leila Katz is doctor gynecology, obstetrician from the Institute. Please, Professor Dr. Leila Katz. Invite to our table the same institution, Jailson Barro Correias. Jailson, could you please come to the table, please? He's doctor from the University of Liverpool, England. Adjunct professor from University of Pernambuco. It'll be a privilege to have you here with us as well. Please come to the table. Well, we're going to invite now those who represent the Hospital Eduardo Campos from Senior Citizen Sports and Health in Recife in Pernambuco. Please come to the stage. Thais Severo da Silva, please. Thais is a nurse. She is a master in intensive care, doctorate in nursing, nowadays director of teaching on the elderly. Professor Thais, please. Now I also want to invite to take a seat at our table the representative of the hospitals and hospital management of the state of Ceará, health and safety. Fernando Agadeira, please. Fernando is a master in physical therapy and management, education management in the institution. And I also want to invite from the same institution, Virginia Silveira, please. Dr. Silveira is a doctor, rheumatologist, a master in clinical medicine, postgraduate in hospital environment, technical consultant and Center of Intelligence of the state of Ceará. Also director of care and teaching and care of the hospital. Ladies and gentlemen, please welcome, take your seat. Please be comfortable. Dr. Coordinator, please feel comfortable, and you have the word to conduct the work. Good afternoon, everyone. I go immediately to give the word to the member of the table. You have each 20 minutes, please. Remember, and some final minutes for additional conversation or questions. And you also have it's an honor to hear the talk and each experience from each hospital. If you allow me, I'll give right away. I'll give the word to Leila Katz. On the name of the Institute of Medicine, Fernando Figueira from the Secretary of the Ministry of the State of Ceará. Please. I would like to take advantage and thank the invitation under my name and the group that participated in this project. Thank you for this invitation so I can contribute with this great challenge that we all were presented with, and also the invitation for being here today. Will I be the ones passing these? Okay, our team will do that. Thank you so much. Well, so first of all, I would like to show, for those who do not know, the service that I'm representing, Integral Medicine Institute Fernando Figueira, IMIP, that was founded in 1960. One of the founding members was Professor Fernando Figueira. It's in a hospital for patients from SUS, the United Health from Brazil, and also for the Ministry of Health. This is, you can see the picture. The service is composed by 10 buildings. It's 100% SUS, the United Health for Brazil. More than 4,555 employees. The hospital, just out of curiosity, initially it was the one on this corner right here, the little blue one. This is the one that was founded in 1960, and it was exclusive pediatric, and then became neonatal, and then expanded to other areas. It has infirmary for adults and children, cardiac patients, a research lab, outpatient, and obstetrician. In our area of assistance, we have professionals in different areas. Integral for the patient, from biomedicine to physical therapy, phonoaudiology, more than 40 specialties among our professional psychology, social service, occupational therapy, and so on. In relation to the numbers of our assistants, from 2021, we helped over 2,000 births. Even though the pandemic was around, but normally the number of births are larger. We helped in 12,000 surgeries, 40,000 hospitalization, more than 100,000 emergency, 167,000 image work, and 2.2 million help and therapy and help. The same year, 2021, I call attention to the number of our teaching, more than 1,300 students in graduation and post-grad students as well. During the year 2021, what calls attention is the 15 groups of research that we have in the institution. It was more than 773 research and articles published in the year of 2021. What happened to IMIP during pandemic? In February 2020, we were invited by the main office in Pernambuco to help specifically the children with COVID, and also women, the pregnant women, and those who had soon delivered babies. We were also helping adults in general. In February, we had more than 50,000 beds open, more 20 pediatric beds, and 53 beds in the infirmary. In February, all the assistants trained for all of the group, in March, all the helping protocol. We helped adults in ICU, and 20th of March in 2020, we had our first patient that was hospitalized with a suspicion of COVID. We are a reference hospital and tertiary in the state for obstetrician in general, and basically modified the profile of all the patients that we were helping. The sentence that our colleague mentioned earlier today is the same one we repeated all the time last year. It was like changing the tire when the car was running. Specifically, the evolution of COVID during pregnancy was what worried us the most. The idea that all the professionals were working, it was a question. Do you think pregnancy is going to make it worse? No one knew that yet. Thinking about that, not just the characteristics the unique characteristics that each pregnant woman has, but all the physiological changes. We go together. We looked at other respiratory issues in the past as well. And the population that IMIP helps is a poor group and more vulnerable ones. We thought they most likely have a more difficult prognostics. Now, a little more detail is that today we have this already. We have this very well established, but of course not just China and Italy were calm about it. We weren't. We believe that we could have more challenge, a bigger challenge for us. But today we know that pregnant, what they face, we know a little more. They might need ventilator, and the death could happen. And we have a issue, and possibly a premature birth is also something that may happen. In the neonatal and maternal issues, preeclampsia risk, adverse reaction, prolonged admission of the baby after he's born, long hospitalization. This bulletin shows what happened during the pandemic with pregnant women. The objective of what I'm going to show you now, we need to call attention to not just show data in the pediatric side, but also the pediatric area needs to be improved. And I'll bring here the part that we're going to show today is the sickness and characteristics in the patients, not just those who are pregnant, but also postpartum. Now then, I need to show you the history. Our hospital is another challenge. It is at this moment implementing electronic chart. Back at that time, during COVID, is when we started to implement this in the ICU. So at the time, we were not able to get the data this way. The fact that this institute is one of research, and Professor Melanie Amorim and Alex Sandro and we got together and formed a study group about the gestational period of humans. And what I'm going to show here is a study, the data bank from the original study. It's a cohort direction specifically to evaluate these patients. The original studies was approved in IMIP in June 2020, and the result was accepted at CEPI only on the 14th of September in 2022. In reality, we were not called to participate in the studies only in the initial stages in August, but in September was when we were able to use this data bank that existed prior. This is how the study was developed. Well, the original one, where they got the data, was typed in the digital data and facilitated more and more the export of data in the original data. The first study is included from data in and it was for this show, we're going to show you the result of 782 patients that were helped in IMIP.
It was made a comparison and a standardization of the red cap for the study. and we tried to standardize the way the data was collected to what was necessary. It's important to say that many variables we didn't have because it was a different study that thought about variables in a different way and we couldn't use those. Now we're presenting the results. 782 patients that were COVID-19 patients or that were suspicious of having COVID-19, and 71% were positive and 18% were negative, and many of them collected their exams in an improper or in a wrong moment. Comparing to others, this number is quite elevated, but we at that time we were the only reference center at Pernambuco for for pregnant women, and that is why we have this high number. About the ages of the participants was from 12 to 46 years old. 85% were admitted during pregnancy, also postpartum, and also molar pregnancy and ectopic pregnancy. Now, I want to explain to you that we became a reference to the whole state and region for pregnant and postpartum women. And they came to us complaining about COVID, but also, for example, with other problems during pregnancy, but they had a positive exam for COVID. So the women were in their 36th week of pregnancy, and about the comorbidities and associated disease, I wanted to call the attention for the hypertensive syndromes, which is different from something that we hear in Brazil and abroad. But this is because, as I said, many patients were committed to our institution because they had preeclampsia and they didn't have any symptoms for COVID. So we had patients that were very serious, but we also had patients that had eclampsia, preeclampsia, and also HELLP syndrome. So we had other disease like diabetes and cardiopathies, and also the nutritional state of the patients calls our attention because we didn't get the height and the weight. It was very difficult. But in the 273 patients that we were able to collect this data, they were overweight. So 179 were pregnant. So not always this was the cause for the interruption of the pregnancy. So we had SARS in 247 patients. 181 were in the ICU. 202 needed oxygen. Corticotherapy was used in 189 patients, and ATB 310. I was very disappointed with the frequency of antibiotics because I thought it was exaggerated, but comparing to others, it was reasonable. And I believe that this was due to very recent manuals and very rigorous manuals condemning the use of antibiotics, and that didn't have scientific support. But in these patients, we noticed the near miss in 55 of the patients. If we consider death, about the COVID-19 patients, 18 patients, and this represents 2.3% of the total, or 3.3% of the sample. It seems high, but comparing to national statistics, the mother mortality was compatible. We had 26 fetal deaths, And the time of hospitalization was about 3.6 days. For those patients that died, the average age was a little bit higher. There are 44% of comorbidities. So we had 6 hypertensives, 1 cardiopathic, and 1 asthmatic. All of them were in the ICUs. Sometimes they spend 12 to 24 hours in the ICU, waiting for an ICU bed. As I said, many of them were committed to ICU, but we know that there was an overload of the system, and some patients, they spend almost 24 hours waiting for the ICU bed. So although we have a high number of ICU beds, as our service was a reference to the region, we had a waiting list to commit patients. But pregnant women were considered priority in the waiting list for the ICU beds, so we didn't have any patients that needed ICU beds and didn't get one. For those patients that died, 72% needed mechanic ventilation. The others, they died before this therapy. Some of them got admitted directly to ICU and they died right after. The corticoid therapy was used for 77%, dialysis 27.7%, and ECMO 2 patients representing 11.2% of the sample. For a challenge, as a challenge, it was something that we all had. For this specific project, I say that the greatest challenge was the fact that we didn't have an electronic record. We didn't put this in a practical way so they can be extracted. Luckily, this study was undergoing and we could take advantage of secondary tertiary data, and there were many variables that were codified in a different way, were imagined a different way, so not all the variables that we have in the original database could be used. Also, during this pandemic, we learned a lot, we exchanged knowledge, and there were some variables that we didn't see in the beginning, so they were just added at the end. So this is very incomplete. There are a lot of information missing. There is a lot of information missing, sorry. And we have a mortality rate that is relatively low compared to other groups, and obesity can be highlighted. It is very serious, and there is an elevated frequency of CIRAC, of mechanical ventilation, and also we see this in many studies, not just in Brazil, but abroad. And data founded about the conclusions are very elevated, but this possibly is due to because it was done in a tertiary hospital and it is reference for serious patients in the region. That's what I wanted to present. Okay. Thank you. Thank you for your presentation. Now, Dr. Jaisso Barros Correia is going to talk about the Institute experience. Good afternoon. On behalf of everybody, on behalf of the hospital, I just wanted to report very briefly a movie that is going in my head, because the last time I was in this auditorium was as a health secretary of Recife in a meeting for COVID specialists in the beginning of the pandemic, and Margarete Dalcomo was here, Júlio Coda was here, and there was a lot happening since then. First, there was the first time that the Ministry of Health said that the Ministry of Health said that there was going to be a huge impact on the citizens, and the feeling that we had was that term in aviation that says that we could say brace for impact, where you put yourself in an emergency position for impact. So that was the feeling. After these years and this gratifying experience, we can see how the Brazilian hospital network could contribute to science and their important outcomes, as we can see. It is avenue of possibilities. I am responsible for the pediatrics department, and while there was a research project that was happening before for pregnant women, the reports were made physically and we rescued them. It was the old way to do it, and we use them to contribute to the platform. So we're still maturing it, and the expectation is that once it is made, this electronic platform, this electronic chart, we can still contribute to the platform. Thank you. Thank you, Jailson. And this also brings the perspective of the researcher, and this was responsible for the Brazilian response. It was very necessary in the pandemic because our country is really big. Thank you very much, Jailson. We've known each other for 32 years, and it's a pleasure to be here with you. So now I will give the floor to Professor Thais da Silva. She's going to tell us a little bit of the experience of Eduardo Campos of the elderly people in Recife, Pernambuco. Thank you, Thais. Good afternoon.
Good afternoon, everyone. I'd like to start by thanking your invitation. Eduardo Campos, he works for the senior citizen. He has completed 2 years, so he is new and it's challenging. And the research group is only 6 months implemented. So with the invitation for OPAS, Pajos OMS has conducted with great wonder this study, and it's highlighted for an institution. For you to understand a little bit the context of the hospital, it is the second hospital that is focused on the senior citizen in Brazil. It's a municipality area and works with SUS. And the priority are these patients over 60 years old. Professor Martin Ferrandes is managing it, and it was inaugurated October 1st in 2020, World Day for Senior Citizens. Here you can see and observe that we are localized strategically between all the sanitary districts that are forming the city of Recife. Near districts 6 and 7 is where you find this older population. Lower part of the hospital you can see is formed by the infirmary, by the outpatient and inpatient and administrative part, which is very important for us to understand how the flow has been done at the time when we were a reference for COVID-19. The outpatient was working very well, and all the hospitalization was focused on those patients who were suspected to have and those who have a positive diagnostics. This is also the outpatient area. Interdisciplinary area, The services offered are total of 13 professionals: EMT, INT, nutrition, psychosocial, which is social work and psychology, and again nutrition. In the medical area, we have 14 specialties: cardiology, endocrinology, gastroenterology. Our diagnostic center is also very strong. We have 12 types of exams. Some are going to be implemented at the end of the year, like endoscopy, colonoscopy, aerodynamics. And we have 60 beds in the infirmary, 10 ICU beds, and 4 surgery rooms. All the 70 beds were transformed into intensive therapy to help the whole population of Pernambuco. And this is how we start inside the pandemic. March 2021, we opened the door to offer help for these patients. So 70 beds were for intense therapy and had several flow that were shared by our colleagues, how the circulation work and protocol, safety protocol, and all the norms and technicalities. And it was very challenging to collect these data. Today, we still don't have an electronic chart of our own. And with this, the resources for research are limited. To fill out this information from the professionals still needs to be improved. So when you have a patient talking to a doctor and he talks about diagnostics, from February 2021 on, that's when we use that to get these patients. Well, you can look at the first graph, the case of COVID-19, total of 619 senior citizens, 352, which is 57% of our sample, they had positive results. Most of them were men, their sample of more than 51%. Graphic 2, we see their age, the population of 62, most of them being the majority. And here I synthesize the findings. The hospitalization, the median time was 10 days. 32% of the sample that we used, they used mechanical help, and 26% and of this 27% had to have a tracheostomy done. 24% use intravenous drugs, 73% corticoid, and 96% antibiotic therapy. And then we reinforce each protocol. It's important to start the treatment as soon as they were diagnosed. So the clinical closing, we unfortunately had a considerable result of death, which is 58%. Of transfers to other hospitals were 24%, which mostly went to infirmary. Since we only had intense ICU care, once they were discharged, they would go to other units. 18% were discharged, and 6% went to palliative, which now we just started it inside our institution. We inaugurated it. And here on graph 3, discharge versus death, you can see through timeline. Graph 4, you bring the line of deaths on the same time. And as a challenge, here you have the scenario which is surprises and challenges. They have all shared difficulty and structure and team. Difficulty in collecting data, like I said earlier, our chart is not as strong. It does not have all the information and not all the tools that are essential to bring up these data. It was taken to the general directory, so it could be improved, so that we can use that for future contracts and the team that work with this electronic chart, and also strengthen the research that we do in our institution. The knowledge and the perfectioning of this, we used a research based on evidence, and that would strengthen the role of education inside of our institution. It's of utmost importance. And the fact that the patient were severely sick, it was important to have a multidisciplinary work together with the patient's family in the integral basis. I would like to thank especially Roberta Monteira, Cintia Avelino e Felipe Costa. They helped us extracting these data. Our patients, those that we give back to the family, and those who unfortunately are no longer with us, and all of those who makes Eduardo Campos the Hospital for the Elderly. I leave here our contact. I invite you to get to see our institution. Thank you so much. Thank you very much, Director Thais. We give now the presentation of the management of the hospital in Ceará. We start with Fernanda or Virginia. Okay, we'll start with Virginia, Professor. Good afternoon, everyone. It's a huge pleasure to be able to participate in this moment and to talk about our trajectory. It wasn't different from the ones you lived, but certainly brought us a lot of growth, and all of you, just like it did for all of you. I'm here to present the experience of the Institute of Hospital, which is an institution that was initially, I think it was over a little bit further. It was founded in 2002, and then it was later qualified by the state at the end of the year of 2002. So we're going to be there 20 years of history at the end of December, 20 years of ISGH. And the great objective in ISGH, this organization, is to work with quality and to help you solve problems in the state of Ceará. We now have a contract with the health secretary and the municipality also. But most important now is the secretariat of the state. I bring here a little bit of the line we work on and how challenging it was. We have several hospitals. Among those tertiary, secondary hospitals, we also manage some. We have 9 units that we attend. We manage. We share the management of health places, and we have a long challenge because we have hospitals in very small areas of the state. Some of them, 3 hospitals of them, are accredited by the UN, by UNA, and UNAXA. It's a big challenge to take the quality to these hospitals. All our beds are 100% SUS, and so we accept patients from SUS. I want to say that in 2020, if you look, we have a hospital called Hospital Leonardo da Vinci. He started when the peak of the pandemic, and it's a private hospital where the state needed to um, fix it and to attend COVID patients. So during the pandemic, this hospital was organized. We hired people, we thought about all the flow and the process of safety for us to help the COVID patients in Fortaleza.
So Leonardo da Vinci was a big challenge that we had to work with in Fortaleza, but we had other hospitals where we received COVID-19 patients. Recently, USGAGE, which is the social organization that was here in this auditorium, they received the certification of 3 quality hospitals. One of them is Valdemar Alcântara de Costa, that we work with in Fortaleza. In the network of ISGH, okay. So this was the one that recently I mentioned, Dr. Valdemar Alcântara, in also the regional hospital and the regional hospital of Cariri. They received the quality certification. During the pandemic in the Ceará, we start working. This is the reality up to March 2022. We have an estimated population of 1,300,000 cases of COVID, and we had 27,000 deaths. In this scenario, ISGH couldn't be outside of this work, and we were designing our projects, our protocols for the patients that had COVID. This is our geographical distribution in the state of Ceará. We have hospitals in Fortaleza, one at the Vale do Jaguaribe, one central hospital, one at the south part, Cariri, and one in the north region. These hospitals are quite diversified. Some of them are closed doors, some of them are open doors. The north hospital and the Cariri are open doors, so we served about 64,000 patients a year. And with the pandemic, we had to restructure them. We stopped the elective surgeries because there was a high volume, and everything was structured again to COVID and also to other processes. Some units have pediatrics, others have service to pregnant women, also others to adults. We have medical residence program, and we have a lot of agreements with education facilities so that the students can do their internships here. So when we talk about our beds, this was the reality pre-COVID. So we used to have 323 beds in Fortaleza, and also Valdemar had 235 beds. And in the peak of COVID, we had 160 ICU beds. So we had critical patients coming from basic care units and other centers of Fortaleza, and we had this number of critical patients. The regional hospital had 481 beds with 113 ICU beds. Cariri, 288 beds with 50 ICU beds. Sertão Central, 211 beds with 50 of ICU. And this one is a newer one that completed 1 year. It was built during the pandemic, has 58 beds with 10 ICU beds. So the total number of beds, we have about 1,600,000 beds and 500 of ICU beds. During the pandemic, we got to 1,000 COVID-19 beds, and the rest was for the ambulatory. So it was a dynamic process. We learned a lot. We set protocols, hired people. We didn't have a lot of human resources, and we were overloaded throughout these pandemic years. And we had the process of having many ICU beds. And I've listened to our director, and he said, today we have 500 ICU beds with almost 1,000 COVID patients. How can we work with this? And our work was to disseminate throughout the region a uniform thinking of treatment, of therapeutic conducts. Leonardo da Vinci, this hospital, we had a lot of research work. There was one of the places, where we developed the research. So we had the partnership of other hospitals and with the public health school. This was very important and valuable, so we could get to conclusions and save lives. Okay, Fernanda will continue, and throughout the process, we're going to exchange some information. Thank you, Virginia. Fernanda. So good afternoon, everyone. Continuing the presentation, I'm going to show you a little bit about the characterization of the patients that we included in the study. Dr. Rosani sought us with this challenge, and we thought that it will be great, but it wouldn't be easy, because we were before a pandemic, and with ICU beds being open every day, and also conducting a research and involving the personnel from the ICU, from changes in the routine, changes in the flow. It was very challenging, but very gratifying, because at the end we can see things differently, and we can see our flaws, we can see our weakness, and we can see where we can improve, and we can collaborate with the profile in our country in regards to COVID. And we're sure that this is going to change a lot of the outcomes. So we have separated the suspicious hospitalizations, and we have identified more than 28,000 patients that were suspicious of having COVID. When we got deeper into that search, and when we looked for confirmed cases, the number dropped to more than 20,000 patients. Out of these cases, 14,000 were ICU cases, and unfortunately we had more than 8,000 deaths. And this is equivalent to some findings of the deaths that were happening. This is a graph that is showing the evolution of our hospitalization. We had about 11,000 discharges in the period from 2021 to 2022, and it was very characteristic with the waves and the vaccination, with the variants, with the mortality and number of cases in the patients. So our sample is predominantly male patients, and we had an average age rate of 45 to 65 years old. Deaths with comorbidities and without comorbidity, we can notice that 52% of the hospitalized patients with COVID confirmed were patients with comorbidities, and the ones that are most common were diabetes and hypertension. And then we can see our scenario with our ICU patients. 50% of the patients out of those 28,000 patients that were hospitalized in units, they have developed a clinical worsening, and this has culminated with the need of an ICU bed, with most of the patients being male patients. So when we talk about ICU patients, the age rate is about 66 years old, and it corresponds to 44% of the hospitalizations in the ICU. The patients with comorbidities represent almost 60% of the patients. So what are the challenges? What are the lessons learned? Our biggest challenge is to give a quick and safe answer for society during the pandemic. When we were invited to participate in the study, we've noticed that the integration in the Brazilian health system would be a challenge, but also the integration in our internal system, because we could notice that although we had electronic report thought on the reality that we had, this study made us reflect how much we have to develop in terms of electronic system, non-structured fields, gaps, and also the extraction of data. A lot of things were not available because we couldn't see. There are a lot of data, and we had some structured data, but they were not filled. And when you went there and would write the evolution, you didn't have the information. So the professionals, sometimes they missed, they didn't write the information, and we had to rethink how to improve that. Another challenge was to have health teams ready. So we had to hire abruptly, and there was a lack of qualified professionals for this. And there was a challenge. We had a permanent education that was in the format, in a different format, and we had to change the culture in the middle of the pandemic. So this made us rethink our process. The pandemic's not over yet, but we have to think about the challenges, about developing training techniques, and we have to stop thinking that in-person training is the best option, and it's the only option. And also, there was a heterogeneity among the many regions in the country about the management of information. Our country is really big, it's continental sized, and we have to think together. We are gathered around the same purpose. So we have to think about each service, each basic care unit, because similar things happen. There was a lack of equipment, there was a lack of kits, there was a lack of human resources. So this is the lesson that we have to have in mind. Those who had more resources or less resources, doesn't matter. There was a lack of medicine for everybody, a shortage of medicine for everybody. So we have to take a look at the management side and we have to take a look at the data, because we understand that today managing hospitals, managing information is a challenge, and it allows us to see better our situation. So the greatest lesson that is the importance of the sharing of information. We can't live without it. And now the challenge is to have this experience. And during these 2 years, how can we continue to do it? Because we need that. We need to think about a model that is more unified and uniform for all the country. So we would like to thank, while on behalf of ISHG, for having participated in this project and also here with you. These were very rich experiences. Thank you.
I thank you one more time, Fernanda Virginia, and I think us here have had two very significant experience from different states. And I ask, I believe, Rosane, we could go through the micro regions of Brazil. In fact, we need unique answers, but these unique and unified answers need to be very diverse, just like our country is very diverse and our nation. So in this way, it's very interesting that we can conclude this round with two presentations who comes from the managers, from the municipality, and the Secretary of the State of Pernambuco, and the experience of Eduardo Campos Pessoa from the senior citizen, from the municipality of Recife, and the managers doing their executing their planning and managing capability, and from ISGH, from Ceará. The representation from the Northeast makes it worthwhile to see what that a son of yours don't run away from the fight, as we say in Brazilian anthem. Now we go straight to give the floor to those of you if you have any questions in the audience, and I thank you one more time for all those that represented here for sharing your experience, and our representatives. Thank you so much. Please. I think that we may have a limit on how we can hear you. The microphone in front of you is on. The one right here. Thank you so much. Good afternoon, Michelle Valeria Paiva. I am representing the Secretary of Health of the Federal District. I'm recently retired, but still I'm bringing the word from the Secretariat. I'm speaking on my behalf. I've been with SUS for 32 or 33 years. This electronic chart question is something very recurrent for many years. It's a challenge we have when you talk about systems. I remember HCPA and all the other ones that were bases so they could do the work, because Rosane and I were there, right, Rosane? Well, you were there in IBC. But the question that I have is, when are we going to have this challenge to make this unified chart so that all this database one day can finally one day have a concrete database so we can do this and all the other researches that are necessary on the area of health. So a colleague from Ribeirão mentioned today that maybe there should be a law to make this normalized. And so I am a little anxious, because there's at least 20 years that in the ministry we have been talking about this. It's a lot of public funds invested in this question. It's just a provocation, a question. Maybe Dr. Ricardo could maybe give his opinion. This is my dream, though. I just want to say that this is my dream, if maybe we can have something unified someday. I believe that we have a very instigating issue that I bring the word from Dr. Giuseppe that represents EPSEA. He says they pass through us, the hospital, say, if I'm not mistaken, 9,000 students on an annual basis, and they are the big management of, they have this tacit knowledge, but we need to use it so that we can manage all this knowledge. There's an important experience in literature that little by little is being translated into the Brazilian context, that are forms of make it more formative way to evaluate medicine. I'm thinking about the future, the EPSER, the figure of Dr. Giuseppe, which is professional activity that are, which is a process that I show in the perspective of the services, the abilities and knowledge and competences that all the students of medicine need to develop in a formative perspective so that they can correspond to the abilities that are acquired, but also the national directives. And these professional activities be translated to Portuguese. I'm one of the people who was also, who graduated from the Rio Grande do Sul. Our group obtained the authorization to translate this. It was one of the we had this 53 medical we expect the student of medicine when they evaluate a case, and we expect when they present a case in a discussion or a case study or an obstetrician, for example. And what do I expect in a matter of behavior when a student of medicine do the registry in a chart? The behavior from the students that we are already a little bit experienced. We have some pilot plan. So again, I'm echoing what Dr. Giuseppe mentioned. We start on the basis. No regulation or norm or directives or legislation is up, down, is never top down. We need to stop and do it bottom up. So I believe that these experiences and diversities, and especially a work from basis that needs to start being diversified. The important task of this is to make the management in the hospitals, but all of them can be done by partnership, and the tools are there, and we can define a process of making all the students in medicine do that, and this could be applied in all layers and multi-professional team. Questions, comments, colleagues from the table, if you'd like to mention anything. Virginia, please. So just to complement this challenge of integration, we have these hospitals, they are in different regions. We have a network inside Fortaleza, and we have this huge challenge that we have put out there for the 23rd. It evolved very little, able to integrate, at least search others with other expertises, because it's a huge problem. When Fernanda brought this challenge of doing this research, we were a little worried, concerned, but we said, let's go, and we saw that there really are some important things, some positive things, and a lot of things to improve. And those are important. So we're going to try little by little. We see that there are many people that are interested in this, and we want to continue this project together. It's a little more challenge, and I believe it's everybody's dream as managers, and we have been there before. We also helped patients in the past, and it's a question that all of us should walk and share in this area of education. When I graduated, we used to do things by hand, but now we have to teach them to do it electronically. This movement, we're going to work on this movement, but the boys now, we should say, let's do a session and use the electronics. So I also put myself available with ISGH that has places to work on that. I thank you, Professor. I'll give it to Jailson right now. I forgot to say how happy I am with the Hospital Eduardo Campos that was inaugurated that one day for the senior citizen. And here in Opus being presenting and work, I'm really happy for this. We should celebrate the happiness for it's really because it's really hard. It's always a challenge. I would like to reflect upon this whole question, how difficult it is to change behavior in the register, in the charts, be it electronic or physical. The reality of nowadays requests a behavior change. It's a complex process, almost like a generation, so that we can obtain definite results of these medical records. I bring so that when we talk about a law that forces it, we may be able to, with the same possibility that the technology brings, what they bring, and to incorporate this information automatically. It's a technological matter over here. We are living the area of the wearables. My watch here is giving me my heart rate. And of course, some people say they give you more, but I don't believe. I would say that incorporated technology with the passing of time makes you think of how much can we integrate information, and those that are instrument of measuring things. And so I believe hospitals have huge opportunities for that, and this naturally will start eventually being a form of things to be used in the medical records. And it's a reality, a huge celebration that brings a lot of contribution. The quality of the medical records are very important. Look at night. If you have a night shift and you look at these medical records, if they're adequate, it's very important. Even more than, not less important than the research. So I keep seeing this. Very happy. When I used to be a director of DECICI, I was a director of DECICI here in the Ministry of Health in 2012. It's been 10 years, as we joke, but we used to talk about the question of the possibility of the actions being incorporated and dreams of being integrated. I think it's a fantastic thing. The company they work with hospitals, and they have a lot of technological challenges, but gives opportunities. So in this moment where we live a transition into incorporate the hospitals themselves with post-graduation, CAP 6. I'm not sure if it's a good time to talk about it, but IMIP, when we did this job, has a post-graduation level 6. It's not just, it's very important for federal institution, and we don't have all the sectors yet. We have huge opportunities to cut some space and build a logic, thinking about the future environment when the integration, Internet of Things, and all these elements that can feed a huge net of artificial intelligence, and what's going to help us make better decisions in the real time. So in real time, clinical management and public management as well. Maybe that's, from what I know, the project that in Brazil, I'm not sure if I'm exaggerating, but from what I know, in my knowledge, that in Brazil we're able to have this representativity so big, and even though our country is huge, so this project is above all a breakthrough. Well, I mean, we're like the virtual knife cutting through the forest, almost like a new forest, leaving behind steps, positive steps, and positive results for. And those, so this is my optimistic vision for the future, for all other things that we want to do. Thank you, Jailson. Thank you, Giuseppe, please.
EBSER was mentioned many times, so I have the right to respond. I'm joking. But we could bring some very innovative things. Eduardo, Adriana, who are here and are from our coordinated group of health research and innovation. We have tested some things. We have tested that. And we had a test of a software for the surgical center, and it works. You don't need the anesthesiologist that is doing things halfway. And it's possible. We believe in that. Instead of buying a um, conventional scale, I'm just going to buy one that is connected to IoT. And how much is that? 100 reais? So this is nothing. The time that I save for not having the technician do that, it's something that I already have as a benefit. So this doesn't cost anything. So it's very likely that the path that we need to follow is the IoT, to have the systems working more for us, and that people do not need to do the labor work. They have to spend their brains, not their muscles. We when the processes become intelligent, smart, and they are consolidated, we are going to start analyzing these data. You are very right. We had an analysis in one of the hospitals. This was presented to the Ministry of Health, and we took a disease and we took a look at the whole line of the disease. So this was something innovative. We have the budget, we have the interest, we have everything that we need to do that. And when we do this with cancer, for example, we do this for the whole hospital because it takes a long time and it takes a lot of efforts in the hospital. And we have to bring technology like the wearables. So imagine if we could give an oximeter to the patient and he can monitor, he can send me the information when I have to see the patient again. My father has a serious disease and I have to monitor him every day. And when he is in crisis, he has a high temperature. When the temperature is high, I know that there is something wrong. So this is simple, just by measuring his temperature. So we have to improve this. It's going to be simple, and then just simply changing the culture. The students that are graduating now, they just have apps ready for that to solve his or her problem, and we don't understand that. We don't know how to do that. So maybe the wearables, the IoT, this kind of technology will solve more problems, and it will be easier and cheaper than to transform the whole generation's thinking. And I love technology, so I think it's easier to do it on paper because I have been doing this for 20 years. So for me, it's simpler. I think this is the right path. Okay? And also thinking about strategy and changing of culture, we have to take a look at the processes. EBSER brings something different because we have health schools that have more than 1 century. So the scenario of practice for these schools has been working for century. But the main point that he brings here is not just about the perspective of the wearables, but to rethink the environments, rethink the spaces where we have practices. We have to think about the 2 decades of guidelines that we have in the courses, and we have to take a look at the perspective of what is defined are the services. Any other contributions, please? Ronaldo. So I would just like to thank you. Thank you for the work that was developed these 2 days. And also, data analysis is really important. When we redid the analysis, we have to interpret these data, and we have to see that the characteristics are very different and also have some similarities, and this is important. I have a lot of notes for Janet and Sylvia. I have to tell them the whole story. I would like maybe add 2 keywords to describe the event. One is responsibility. Everything that was done here regarding data, I noticed that there is a lot of responsibility. Everybody was very aware the way the data was extracted. They were concerned if that makes sense, and also honesty, because there was a person that said this percentage of death, of ICU deaths, I don't know if it makes sense. I have noticed the same. So the responsibility is important because it helps us understand data, and also that we are in the same situation. But when we compare to other countries, and we have data from 66 countries with many differences, but the perception from Janet is that we are quite advanced. And we know that Ecuador, Colombia extended the event. I think there will be another discussion, so thank you. I'm very happy. We thank you, Ronaldo. We know that there is the moment to give the word to our master of ceremony, but we want to thank everybody at the table for the experiences presented here. Thank you. Ladies and gentlemen, thank you so much for your presence here at the table. We are concluding now the works presented at the seminar, and now we're going to have our final consideration and closing as it was foreseen in the program. Thank you. Now we have here at the table Dr. Roberto Tapia Hidalgo, Health Systems and Services Coordinator from Parro, Brazil. We'd like to invite Mr. Ludovic Reves, Regional Advisor, Evidence and Intelligence for Action in Health. I would also like to invite to the stage and to be at the table Rosana de Mendonça Gomes, technical consultant in health services from Parro, in Brazil. Please take a seat at the table. Now I'm going to give the word to Dr. Roberto Tapia Hidalgo. Good afternoon, everyone. So we're closing this meeting. These 2 days were very interesting, and I have listened to a lot of things. And this is an area that is regarding the health services, and this is being developed with a lot of strength in Brazil. And there is a lot of interest, there is a lot of strength during the pandemic, and this is quite strategic in the service scope. So, first of all, I'd like to invite the team. This is fundamental. Nothing would be possible without the team of researchers and everybody that came here. I would like to especially thank Ricardo, Gabriel, Eduardo, Fernando. Those are the ones that have more contact with the researchers. Monica especially. Monica, thank you very much. So, we're advancing fast. So I would like to thank everybody. And now what to do? What are the considerations? First of all, it's about the information system and technology. I came from a world that we had about 100 hospitals. And the first road, so the hospital is working and the professional is working, it's a simple process. And this is a world that demands a lot of technology from us. And we're not talking about generalities or giving a lot of general messages. So we have to invest in central technology. And we have to do data processing, analysis, and also invest in human resources. We are going through the right path, but we have to communicate with people. And also develop understanding and analysis capacity. I don't understand that very deeply, but I feel that there is an opportunity so we can advance and to share in this, and we have advanced in that. And we have to have the system for the hospital. Many times we did that, each one with his or her own specialty. And we are committed, and I think that this will support strongly during the process. And we're going to continue moving forward. And all this network, all the hospital network that has science, technology, research, and they do that. So this is very powerful, and we have to continue moving in this path. We have to make a research, and we have to do this because we are in a condition where we are facing climate change, war. Well, we have to solve this, and we have to go back having something to solve these problems. So there are some research spaces, and there is a service, there is the network, there are operations with a lot of other spaces that are develop the process of serving patients. We have to seek how to do that, and this requires a lot of specialists in this area, and we have to abandon the paradigm of investigation to incorporate management of specialties, and we have to explore this. And how to do that? We have to take care of the basic care units, basic care when the patient gets to the hospital or when the patient is discharged. So I discharge the patient and I don't worry myself anymore. So we have to be concerned about that. We have to research what is happening with that patient, and we have a way to do this. We have the vaccinations. I call your attention that the mortality of patients that are hospitalized in the network by COVID, there is a difference. It's very different between the vaccinated and non-vaccinated patients. So we have to seek how can we face this, and I will encourage you to research on that.
We are in a network of research that can have a cooperation between Brazil and others, because it's very important in this area. We have to intensify this cooperation in the SUS system. But then we have transitions in the government transition in this country, which is opportunity. And the other days and the days before that, in this transition, you have strong information, also strongly about the vaccines, strongly about the hospitals. There's a space that I invite everyone to occupy right here. You've been presenting a few days. There's a space where with a great opportunity for advancement in the Ministry of Health, which is a fundamental part, but also with the space of governance that are so powerful and very strong that someone presented yesterday. And those that you have at the table, we have space to and a group of possibilities. And I would like to finish up by just with this and say that personally I really enjoyed these days, listening and learning and understanding, to see that in a way you were able to do this with Rosario and the team, and giving us space and making our job possible in the way I hope to that this will be useful and make it work in the country from now on. And this is all I'm going to say. Invite you to keep in touch, and then Rosanna, please, a few words, please. After 2 intense days, it was rich, very rich, and these 2 days of event and exchange of experience, all of us sharing our experiences and challenges. Here today, we heard so much. We heard lastly how huge this project is, what all of us, which I include myself, but without you it wouldn't exist, and that you have a great challenge coming, which is sustainability, how to keep it, this huge thing, this collaborative network from sustainability, and what we have constructed throughout the last 2 years. I believe there is a huge challenge from the institutions. Roberto already mentioned it. from PAHO, WHO, and managers, state managers, CONAS and CONASEM, the National Council of Health. At this moment, we have a huge challenge ahead for not losing all that what we have built so far. So how to do this and how to keep going and follow up, not just COVID, post-COVID, but all the other projects that may come in the future because of this. So it's something enormous, and I'm very happy to have had the opportunity to participate in this project. So I'm here, as Ronaldo mentioned, all my thanks from those that I'm thanking. Please allow me, I made a little list because I sometimes end up forgetting. So in the first moment, I really want to thank WHO, Dr. Sylvia, Dr. Ronaldo, and the whole team, but Ronaldo in the specific, because how kind he was. I'm going to be moved now. I'm a little moved. It's too much. Why? It's the way he has treated us throughout these 2 days, Ludovic. It's extremely kind. From Dr. Monica, when I'm so difficult sometimes and giving him so much work to do, but he's so polite and helpful with all of us. So our deep, deep thanks to the central office of PAHO, Dr. Ludovic, who believed and trusted us and that has given us all the support so that this project can be conducted since then. And of course to Dr. Sebastian, who is director in the area, together with Dr. Ludovic, has proportioned us all of this. To the Ministry of Health, our great partner, unfortunately is not here with us today, but we would like to highlight their partnership of the Ministry of Health, especially the Department of Urgency and Hospital, and the person who today is Dr. Bruno Carrijo, who has supported us throughout this period. Here, I like to thank how happy I am to have received all the delegation from Colombia and Ecuador for having shared with us their experience, which definitely was so rich, and it was rich for us. So I don't want to forget everyone. I'm going to say in Colombia the name of Dr. Monica Padilla. Not only now, but she used to believe back then in this initial project that has been transformed what it is now. And Dr. Carlos Alvarez from the Ministry of Health in Colombia. Our thank you very much. And the group of Ecuador in the name of Maria Gabriela. Very kind. We talked so much, right, Gabriela, so that you could be here with us today from OPS from Ecuador and Ministry of the Ecuador. Thank you so much. I hope that you can be sure that this sharing will be fruitful not just for Brazil, but for your country as well. Dr. Socorro Grois in Cabia, who has really bet on the project, and I'm really happy to be in this team participating. We cannot forget, Dr. Roberto said, all our team, technical and administrative. I need to now to mention these people. Adriana, who has just left, Adriana Trevisan, Sabrina, the one who everyone knows. Yesterday you had the opportunity to meet her, and Sabrina Lovani, the administrative part of this project. Fernando Ellis, Vanessa, our journalist that's here with us today the whole time, and the other colleagues from the technical unit. And without you, we could not have made this project at all. The help and management of Cassiane Amaral, without her, and the articulation with PAHO and USBN approved it in record time. It was very important. Analisa from PAHO, and all the managers and researchers and as well from the project. So from here I will name the worker complex in Paraná, Cristiane Prates, and our researchers André and Fernanda, who just left. The Brazilian company of service of hospitals, Eduardo Barbosa, Rafael Leonardo. Like Dr. Roberto said, we have a group that sustain all this project, who constituted it as a committee that they are part of. And the hospital, the clinics in Porto Alegre, Mr. Ricardo Luxemburg and Gabriel. I do like Ronaldo. I like to play with him like this. Thank you so much. The hospital, the nuclear hospital Santa Cecília, the Hospital of Base. Again, there's an area we work so much in the Ministry of Health, and there's a huge experience of hospitalization, primarily in the Hospital Conceição of Porto Alegre. I'm going to open something special, Professor Fernando Achal with Dr. Rogério. I'm going to do with Bruna Donida, Rui Flores, and the whole team. I would like to mention Fernando Achal for how the huge time in the process he worked with all the potential and dynamics that he gave to all the works, ins and outs, and the record time. And here I have also to highlight Natalia. She was fantastic. All the team of Eduardo Barbosa. Without them conducting, and of course all the other researchers, and without Fernando, without Natalia, this publication would not have come out. So thank you so much. The Hospital of the Children of Brasilia, who has been with us since 2020, Cristiane, Eva, and the Institute of Hospital Management. He was the first one to participate, and Dr. Giuseppe was the first one to be there in October 2020. So, Virginia, Fernanda Gadelho, and José Gustavo, to MEP and Dr. Ligia, who unfortunately couldn't be here with us for limitation. We were not able to have all, so she chose to have Jailson and Leila. So thank you very much. You have helped us and enriched us so much. On one side, the child, the other side with them, with the experience, with the child and the experience, and then and have a great dynamics. And I cannot forget to mention other ones in the hospital, Eduardo Campos for the senior citizen, Thais, Cynthia, Jonathan, and just presented here. And the hospital Getúlio Vargas from Piauí, and Ivania, André Jansen.
So I would like to send a hug to André, who is not here with us. The Hospital das Clínicas, the Ribeirão Preto Medicine Faculty, Professor Fernando Bellissimo, that was the first one that participated in this. He opened the doors for this project, and they were very welcoming, so thank you. Professor Lívia Pimenta, Júlio César, Diego Marques, Hospital das Clínicas from the University of São Paulo, Dona Heloísa, Shirley, Francis, and all the other collaborators. Shirley, is for all the team. I can't not name everybody because there were a lot of people. The Regional Hospital of Lower Amazons of Pará, Dr. Walter Pena. I would like to thank you for the resilience, the perseverance of Professor Mariana, because she got in the last minute, and it was very good for us. The North region participating here with us. And then the Municipal Secretary of Florianópolis, Ana, had to travel, but I would like to thank the Secretary and the researchers, Ana Vidor, Crerley, and Sergio, for the wonderful participation and for the process, for the study that was so rich. The whole network of Florianópolis. At last, the state hospitals of Espírito Santo, Hospital Vila Velha, and Hospital Jaime dos Santos Neves. And I would like to thank Dr. Nésio because he was the one that immediately said yes and to the project. So I would like to summarize this project in one word: gratitude. Thank you. Now I want to give the floor to Ludovic. Rosana, I'm going to read your list here again. I just want to add and say that everybody had wonderful work, and I would like to thank each one of you. I'm not going to read the names because this has been done already, but I would like to thank everybody from the 66 countries, from all the institutions. We are hundreds of people participating in the hospitals in each organization. I would like to add Dr. Cassian and Dr. Karina from the Center of Colombia and Ecuador for all your support in this process. I just want to close by saying something about the comment that our colleague made about the brace for impact. And many of us have to take flights, but the next steps, how to continue from now on. We started to think for the next 5 to 10 years, but it's very difficult because the technology develops really fast, and the ideas that we have now, other people think also about innovation that we are not even thinking about problems that are happening today. So I would think it's very important to conduct this exercise, to think about where we're going to be in 5-10 years, to strengthen this institutionalized network, all the players, the innovative young people that want to be part of this, and also to take a look at different strategies to improve data, to improve the network, the surveillance network, and all the systems and the health systems, because we have clinical data and also other types of data. And we have to harmonize these, the clinical history that are similar, and also we have many other strategies about the theme that we have mentioned, about the teams that are already connected to the network, And I think there are a lot of opportunities. So we have to think about the next 5 years. We have to think about how to institutionalize that, how to support the regulatory side of it with rules, how to get resources, how to incorporate the different stakeholders, and how to think about the different governmental entities, how to strengthen everything. We have 3 countries that work with this, and also other 66 countries that have supply data. And we have important countries like Spain and South Africa. And this project, we had very good developments. We are in a state of more mature and solid. So we have to think about not only on the details, but we have to think about here at PAHO and WHO, we have to think in the institutions, and we have to think about our role. What we're going to do to build this solid project and more institutionalized project. So this is the task that I will take, and we will try to facilitate this project as best as possible, and also coordinate to get common resources and continue to work and support the development of innovation. So I would like to thank one of the persons that has worked, Rosane and Dr. Tapia, and also my colleagues from PAHO and WHO. Thank you and have a good day. Okay, ladies and gentlemen, I think that's it. We'd like to thank everyone for your presence, for the participation, for the collaboration. For those of you who are watching us on YouTube, thank you very much. Thank you. Have a good afternoon and have a safe flight for those of you who are going home. It's wonderful to have you here in Brasilia. We are always available. We will always welcome you. Thank you. It was a joy to be here with you during the last 2 days. Thank you. See you next time.